Other one. Other one you bring. యూట్యూబ్ లైవ్ చేసుకోండి. కాకపోతే ఏంటంటే యూట్యూబ్ లైవ్‌లో మధ్యలో హాఫ్ అన్ అవర్ బ్రేక్ వస్తే కష్టం. పర్లేదు లైవ్ చేసేసుకోండి. పాజ్ పెట్టుకోవచ్చు యూట్యూబ్ లైవ్‌లో. వెరీ గుడ్. గ్రేట్. చలో చలో క్విక్. హూ ఈస్ డూయింగ్ దట్? కార్ట్ ఎనికి తీసుకోరా. వాడెవడురా ఉండేది కార్ట్ దగ్గర. కార్ట్ కొంచెం ఈ పక్కకు తీసుకో. హేమనాథ్ నీకు కంఫర్టబుల్ పొజిషన్ చూసుకో. సిద్ధలింగ స్వామి, రామకృష్ణ, you come stand here by the side of Devender sir, both of you. Here on the left right side of the patient. Okay, start. Let's start. Chalo, Jai Bajrangbali. Come and start. Okay. Please, no single word. Indrajit, particularly you speak loudly. Don't do that. Okay. Respected chairpersons and my dear seniors, I first of all thank the Euro Onco USA Society for giving me this opportunity to demonstrate robotic assisted radical prostatectomy today. In first I will present the case. This So this is the robotic assisted radical prostatectomy with bilateral PLND. Plan is we are transmitting from the Preeti Urology and Kidney Hospital, Hyderabad. 66-year-old male patient with good performance status. Comorbidities are diabetes and systemic hypertension, controlled. PSA 2017 was 9. PSA 2023 was 17. 12-core biopsy outside October 2023 negative. PSA again came 20. So we have done biopsy. Distal examination has shown hard nodule in left mid apex, right middle of the gland. Prostate volume is 32 cc. If you see the picture here, the predominantly anterolateral peripheral zone of the mid prostate it has. That means posteriorly seminal vesicles are free and it becomes T2C because it's a bilateral disease, and because grade is 3+4, it becomes intermediate to high risk because of the PSA as well as bilateral disease. Keeping that in view, if posteriorly plane is good, we are planning at least on the left side a nerve sparing intrafacial, on the right side extrafacial nerve sparing. This is our plan. Now coming to the pictures MRI, you can see here. Specifically, we went to the MRI specialist and he has shown post-contrast images taking uptake on the anterolateral part of the right and left side. Honestly speaking, apical region, not much the carcinoma is there. Now, this is adenocarcinoma 13/20 course, Gleason 3+3, not 3+4, 3+3. ISUP grade 2, it becomes pattern 4 to 5%. 25 cores are involved, LBI negative and PNI negative. Now, it's a high risk localized prostate cancer, PSA 20, ISUP group 2, C, T2C, it will become no lymph nodes clinically. So, we are planning RRRP and lymphadenectomy. If you see the picture base, there is nothing much, so that I can go bladder neck preserving surgery. In mid gland, 2 are there, apex away from the urethra, 1 is there, that we have to be careful, especially on the left side. Keeping this view in points, now our team is anesthetist Dr. Devender sir, who is senior, and to assist me, Dr. Hemnath is there. To help outside the team whenever we are planning robotic surgery, we need a team outside also. Dr. Ramkrishna, Dr. Siddhalinga Swami is there. As per the team of the Robo SSI mantra is concerned, Indrajit and Durgesh are there. and colleague urologist Dr. Prem is also assisting Hemnath, and I will be doing at the console. Audiovisual team is Mr. Pandu and associates. With this, this is a theater of around 20 by 20. Now we have already put the ports. I will show from externally. This is the head end, and that is the foot end. So all the arms are separate arms. They come from the foot end. And first port is the above the umbilicus, which is the camera port. We are using Olympus 3D camera. Even the Olympus engineer Praneeth has come here to help us. And we have put the right side port approximately 8 to 10 centimeters on the same line. Left hand port is little above 8 to 10 centimeters. Then two instruments on the one is fourth arm, which is in the left iliac fossa, which will help to retract the bladder and the prostate and Foley's catheter during the surgery. Assistants will have two ports, one on either side of the camera port. This is the camera port, so right left camera ports, two persons will be there. I am expecting Dr. Siddhalinga Swami and Dr. Hemnath will be assisting with suction and Himola clip applicators. One is 10 mm, another is 5 mm. So total we have 6 ports. The camera port is 12 mm. The other robotic ports are 8 mm, and one 10 mm regular port, one 5 mm regular port. This is done. Now we will do the docking. In this docking, we are showing the live, so that how much time it will take, it will take. The engineer as well as the urologist will both do the docking. Now, please watch the docking. The uh, camera, first one is the camera port, which is coming, and it is attached. That's 10 seconds. The right side is attached, 10 seconds. And now they are attaching the left side. So if you keep everything ready while doing anesthesia, it will take less time. We can save the docking time. Lot of people say that it will take half an hour. Not necessarily. You can take in 5 minutes average time. Undocking time is 2 to 3 minutes. So whenever there is emergency, undocking time is 2 to 3 minutes. So with this, we will proceed with surgery. My plan of the surgery today is the doing of the bilateral lymphadenectomy, doing of the posterior first, lift the seminal vesicles, try to spare the nerves, and use cold clipping at the seminal vesicles, and then after that drop the bladder. Then bladder neck you do complete bladder neck preserving type of cutting of the detrusor muscle. After that go laterally over the prostate and remove one layer outside the prostatic fascia, so extrafacial nerve sparing, and if possible left side intrafacial nerve sparing. Then go to the dorsal vein. Don't try to suture, cut the dorsal vein and go to the urethra, and then cut the urethra and suture the uretrovesical anastomosis. This is the plan. With this, I once again thank Dr. Shreniksha sir for organizing secretary, organizing chairman of this conference, and the council of the Euro Onco, particularly Dr. Ravi Mohan, for giving me this opportunity. Thank you very much. అది తీసుకొచ్చి ఇక్కడ పెట్టారా? ఓకే. Yeah. Uh, you have to do one thing. Uh, this keep 2D at the moment. When you come close, when I'm showing that, you have to show that also in the screen also, so that you move. I think you people should go away a little bit. 2D vision. He will show 2D from there. Nicely you focus that. Just 2 minutes I will show the movements. After that, I don't have any connection with the live. I will do normally like in Preeti Hospital. But YouTube transmission will go on. Wait. Don't record anything. Because Malli Manak, it's a problem. రెండు చూపించాలి. రెండు చూపించాలి. అక్కడ అక్కడ ఉన్న పిక్చర్ ఇన్ పిక్చర్ రావు. రికార్డింగ్ లో రెండు ఉండాలి. ఒకవేళ start. So, dear friends, I am using SSI Mantra Robo. 1 minute, I will tell. Already we have docked. We are inside. Three arms and camera are inside the abdomen. So, in SSI Mantra, it is an open console system. The vision cart is that is there. Vision cart you show there. Uh, so now I am using the console where first I will use the and I will take out these two. Then only the instrument. This is the first step. The second step is I am taking the clutch. Now my instruments are moving. If you see in the camera, the the left hand is moving, right hand is the Caesar, Now I will go front and back. If I go front, I will go close. I have to use this clutch for the camera. It will go close like this. It will go away like this. And the if you turn the camera this side, you can see the fourth arm coming from the left iliac fossa. And then now this is the uh, if I want to touch like this, I have to go close and then retract this like this. Now, when I wanted to, when they clash like this, what I do is I put the clutch here, then come to neutral position and then operate and then operate. Now, coming to the camera, when you press the camera, the arms does not move much, not at all move. And when you play clutch also, arms doesn't move. In the hand, there is one small white button. If you press, hands won't move. You press and then change like this. So either you use the master clutch or you use the hand clutch, it is okay. These are the four movements. And now we will proceed with the surgery. So many people are seeing Caesar, it is not moving. Nobody is appreciating that. Hemnath, The colon has to move out, Ramakrishna. Cautery is little reduced. Cautery reduce, please. Ready. I am toggling. It is not holding. It's not holding. It's not holding, I am telling. Remove it and keep it again. Keep straight. No, it is not holding. There is gap. Okay. It's a gap. Can you see? It's relieved. Can you move the instrument? Pull back the instrument. Huh? It's not moving. This instrument is not moving. But 90 degrees వస్తది ఇక్కడ. Can you take one more instrument, please? New one. Meanwhile, can somebody retract the intestine? Not like that. Go deep. Take the instrument again. Retractor instrument. Yeah, like that you do it. Correct. If you can go here also retraction. Little more down here. Yeah, go there and gently pull. Don't tease the tissue. Center. Yes, that is correct. That's all. Stay there. Now give open new instrument for retractor. Let it take time. No problem. This is not the correct instrument to retract. Take a new retractor instrument. Prograsper. What is that? No, it's not closing. No. It may slip, Ramakrishna. Chalo, anyway. Ramakrishna has given a good suggestion. Yeah, keep it like this. Somebody, this instrument is not working. Lot of problems today. Where is my other instrument? Where is my other instrument, Emnath? Yeah, bus. Now let's start. Emnath. So I will start from here. Here. Okay. This is the junction. Okay. I will start from here. Okay. Here. Reduce the cautery. Reduced.
எப்ப இதுல இருந்து தானே படுத்திருக்கோம் கண்ணே ஜூம் கண்ணே check Nilesh, can you hear me? Nilesh, can you unmute yourself and speak to me, please?
Hello, sir. Can you hear me?
Yes, I can hear you now.
Sir will be also hear you.
Can you give the mic to Dr. Chandra Mohan, please?
Yeah.
Hello.
Good morning, sir.
Good morning, Anand.
Yes, sir.
I have made a initial video of case presentation.
Very good.
We are in the process of docking.
Very nice.
In the
I can see that you have started doing the dissection.
yes,
That is very nice.
yeah. If you want, you can give live, or else I will do for some time like this and come to important part after lymphadenectomy.
We will keep watching you, sir. Don't you worry.
Okay, thank you.
Thank you very much. All the best to you.
Thank you. You are watching my surgery?
I'm watching your surgery. I'm putting it on the big screen.
Okay, right. Thank you very much. That's of great help.
Zoom 3.
No, don't please. You are not supposed to do the surgery. The suction here. Retract this like this gently. Yes. Rajender call. Retract a little bit. Rajender, take my phone and share the YouTube link in the personally those who have asked.
Recording in progress.
Not two instrument used to come. Now only one instrument is take out the bowel. Ask him to come and do retraction. Am I correct? Yeah, both retract like this. Take the pictures. Yeah. You retract up in the center, please. One suction, one retract. Yeah. Okay, this is the denunvial fascia. Okay. This is the plane. Yeah. Somebody has to retract. Retract this. Not in front of me. Go like this. Go like this here. Retractor here. Swami, go. Retractor here. Somebody retract here. I'm saying my Caesar here. Two retractors are there. Two retractors, Hemnath. One person should retract here. Here. This. Here. Retract up, not inside. నా జోబులో ఉంటుంది ఫోన్ ఎక్కువ ఉంటుంది ఎవరు అడిగారో వాళ్ళకే పంపించు Okay. Can I stop it here? Or can I go further also? Okay, leave it. I'm not able to go more than that. Put little saline and suck. Little saline. Bus. Again. So far, okay, Ramkrishna? Huh? My left hand is not moving. Okay. This is a seminal vesicle. Gas don't suck, Hemnath. Somebody retraction are removed from here. Who is that person who is not able to retract here? Yes. Yes. Keep it there. Keep it there. Gas on, please. I will use the fourth thumb. Take out this. Swami, have you scrub? So orient yourself. Suction, please. Gas. This instrument is causing problem to me. Directly, it is coming onto my. Can I toggle now and go to the. Yeah. Camera clean. Hmm. Rajendra knows it. Rajendra, you don't know the my. కొందరు అడిగారు మళ్ళీ పెట్టేసి ready. Can you take the photo of this?
Who is this Ramakrishna Vijay who has joined in? Sir, please do not join on this Zoom. Ramakrishna Vijay. This is only meant for the hospital's live, sir. Please do not join. Thank you. Chandramohan, sir,
Yes.
how many cases have you done? Chandramohan, sir.
Yeah, I have done 35 cases with this mantra
In a period of,
in a period of 1 month.
wow, that's a huge number.
Yeah.
You are enjoying 3D. We are watching it on 2D.
Yeah, yeah. Can you give the Maryland now?
This is an RARP, no, sir?
RRRP.
Perfect.
See, posteriorly dissection is over up to the apex. See,
Sir, don't finish the case till we stop.
yeah, yeah.
Go slow, sir. Go slow.
Okay, okay.
Rajendra, give sir a good copy.
I want Maryland. Should I take out this or it's okay? Maryland is better. Hemnath. Vas, we have to focus Hemnath. Hemnath, quick exchange. Huh?
But the problem is audio வந்து first line தானே வரணும் உன்ட்ட. So
இல்லைங்க நேத்து எல்லாம் மாத்திட்டோம் நான் செகண்ட்ல
okay, very good. I am getting a good audio and video from Civil. Very nice. Right, நீ மியூட் பண்ணி வச்சுக்கோ.
இல்ல நான் ஃபர்ஸ்ட் மட்டும் நான் பாத்துக்கறேன்னா.
நீ ரெடி பண்ணிட்டு எனக்கு ஃபோன் பண்ணு.
ஓகேங்கண்ணா.
Thank you. நீ மியூட் பண்ணிக்கோ.
Seminal vesicle. Clip. Clip. Yeah, this you take a photo. No, leave it. Hemnath. It is also seminal vesicle. Clip. This is the seminal vesicular arteries. This. Can you see that?
Fifth, that's a huge artery, sir.
Yeah, this is a cord and this is a seminal vascular artery. So we don't want to cut with artery here. Can you see the artery? Pulsations, Anand?
Very, very clearly.
Can you see here this?
Yes. We can
Yeah.
see the pulsations.
Yeah. Go below. Nemnath, don't go deep. Don't go with seminal vesicles. Come back. Wait. Nemnath, wait. Yeah. Now you do it. This is the artery. Seminal vesicular artery. Yeah.
Who's
Wait.
checking the mic, please?
Wait. Now you do it. Yeah. Okay. This separately, if somebody might have taken video. Now, before cutting the card, if you do this, it will be helpful, Swami. You got the point? Before cutting the vas, because it will pull the seminal vesicle. Now I am cutting the very close to. Yeah, wait. Suction, please. I will hold it once I. This is the anterior part. We have to go more lateral. For that, I have to cut it off. Now I will cut it off.
நீயே செக் பண்ணிட்டு இருந்த மைக்க சரி அதான் யாரும் செக் சொல்லி கேட்பாங்க.
Keep ready one Caesar. Extra. It's not cutting. Okay. Now suction. This is one seminal vesicle. Where is other seminal vesicle? This one. This is seminal vesicle or vas? Vas. So same thing we will do it.
Who's assisting you at the table end, sir?
Hemnath and Swami.
Oh,
Somebody is moving my camera. Yeah. So I am coming. This is the right, left seminal.
the camera is under your control only, no, sir?
Huh?
The camera movement is under your control.
Yeah. This is again the left seminal vesicle artery I am dissecting, Anand. Nicely see.
Beautiful, sir.
This is the artery. Clip ready. Yeah. Anand, I am sending the first case record, everything to you.
For the case history, sir.
Yeah, just now I have sent the file.
Okay, sir. I'll pick it up, sir.
See, this somebody record this. This is a beautiful seminal vesicle artery. See, can you see? Can you see the vessel, Anand? Nicely, beautiful. Chalo. This we are not using artery here. That's it. Now I'll cut it off like this. After that, I will cut. Can I cut this, Emnath? This I cut it. Okay. Now, now I will hold both seminal. Now I will do the seminal vesicle on this side. Suction, please. Emnath, you are not sucking continuously today.
Chandravan, sir, you have sent it on WhatsApp or
Huh?
any idea? The case history? You have sent it on...
Case history I have kept completely like a
line. Rajendra has sent it on a drive.
Yeah,
Okay.
that will look natural.
Yes, sir. Absolutely, sir.
Absolutely.
It, sir.
All the docking or everything, 5 minutes.
So I will play it locally. You will see it running and you can talk on it.
Yeah. No, I have already spoken. It's with voice. It's with voice. If any doubts are there, I will answer from
Oh,
here.
so it is with audio.
With audio completely like live.
Okay, very good, sir.
So that if any questions are there, I will answer from here.
You will be able to answer.
Because I am able to listen you now.
Absolutely, sir.
That's it. Thank you, dear. Suction here. Nobody. Come on, Hemnath, today you are not active. Yeah. ఇది మ్యాటర్ వస్తుంది రామకృష్ణ suction Hemnath, continue suction, continue, you retraction से ज्यादा suction now.
Yeah, yeah.
Check, 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 1, 2, check.
Leave it. Yeah, very good idea. Somebody has to. లేదు ఇద్దరు హ్యాండ్స్ ఆక్యుపైడ్ అయితే రామకృష్ణ తొందరపడకూడదు అన్నీ అయిపోతాయి ఇట్స్ ద ప్రాబ్లం suction, continuously keep suction. This grasper is very. Should we take normal grasper? It is sharp. Not normal grasper. Suction, please. Meanwhile, suction somebody. I told suction somebody. Meanwhile, grasper exchange. First, gently, gently. Don't rugged. Who is doing that suction? Please be gentle. Here there is a bleeder. We have to see that. Yeah, go in. No, you are too much in. Yeah. You retract this somebody. Stop. The Euro Onco USA Society for giving me this opportunity to demonstrate robotic assisted radical prostatectomy today. In first, I will present the case. This, so this is the robotic assisted radical prostatectomy with bilateral PLND. Plan is we are transmitting from the Preeti Urology and Kidney Hospital, Hyderabad. 66-year-old male patient with good performance status. Comorbidities are diabetes and systemic hypertension controlled. Dear friends, I am using SSI Mantra Robo. 1 minute, I will tell all of you.
Chandra sir, I've checked both the videos. They are working perfectly fine.
Okay, thank you, dear. I am progressing. Clip again. There is fragile tissue. Vadagurdu. Should this is a respected clip. The most important is not going fast. Okay, leave it. We'll go to anterior. Can you toggle and can I hold both of these and retract like this? See, now suction saline. Saline will help a lot. Do 4-5 times. I will go some more posterior, Swami, because it's comfortable. Keep on doing that. Keep on doing that 2-3 times. Midline only, not lateral. Okay. Retract somebody up. Fourth thumb should I use? Fourth thumb not going that much. No, retractor person don't do that much. No, wait, Swami, please. Pinch dry air. Here we will coagulate. Yeah, suck and show. Suck and show. Retract. Don't, when I'm doing this, you retract like this. Yeah. Then go back, retract. If you, who is doing that? Uh, Side पे आ जाओ, enough. Leave it, Hemnath. You are not giving jaga to me at all. Chalo, wash it. It will go on. You should not be too much concerned about that. ఇక్కడ వస్తూ ఉన్నట్టుంది.
அண்ணா இது சிவில் டியூனோட ஆடியோங்கண்ணா.
Very good.
ஓகேங்க.
Saline suction.
எந்த ரிஸ்க்கும் எடுத்துறாதப்போ.
ஓகேங்கண்ணா. அந்த பிஎஸ்என்எல் டீம் வந்ததுக்கு அப்புறம் நான் இது செகண்ட் கனெக்ட் பண்றேங்கண்ணா.
ஆமா, அது தனியா அதை செக் பண்ணிக்கோ.
அது தனியா வச்சிருக்கேங்கண்ணா.
Somebody retract this. Yeah. Gently, Swami. Gently. Center. You go center. Yeah, stay there. Leave it. Leave it there better. Okay, Swami. Bas, bas, bas. Chale, Swami. Will come anterior. Chalo. Leave it. No lymphadenectomy, direct anterior. Balloon reduce right hand instrument. Right hand instrument. Okay. I'm not ready. Midline, you see midline. Huh? Fourth thumb release. Okay. Can I go here? Okay. I'm not. Swami. ప్రతిసారి బ్లాడర్ ఓపెన్ చేస్తాం కదా అందుకని భయపడి ఓకే Ramakrishna is saying we are going far off. It's okay. Huh? చాలా దూరం ఉందా హేమ్నాథ్ we are far off. If you go nearby Ramakrishna, ladder can open. Little cutting increase, coagulation increase. We have decreased na previously. Okay. Hare, why he has touched cautery? Yaar? This guy is going into cautery. This is inferior gastric artery. No, no. This is obliterated umbilical ligament. Na?
Chandramohan sir, can you hear us?
Yes.
1 second. You have the secretary, the big shot. 1 second. Good morning, Chandramohan sir.
Good morning.
Ravi
Good
here.
morning, Ravi. I have done.
Sir, nobody has joined, so I can speak in Telugu. Huh?
Yeah, yeah. See, I have done lift it. I have done complete posterior.
సార్ ఇంత తొందరగా చేసేస్తే మేము ఏంటి చూడాలి మరి స్లో
See,
because
this,
you already finished half of it కదా so I think you hold on because we start at 8 o'clock. You
yeah, yeah.
want the surgery to be finished by 9 o'clock now.
No, no, no. The time allocated is only 2 hours, na. So
In the next 2 hours there is no there are only 2 OTs going, so there is no problem.
Okay.
Avi, so you will not take 2 hours now because already dropped
Yeah.
the bladder, done the posterior dissection. All you have to do is to identify the neck and finish. Na?
Yeah, yeah, yeah.
So, thoda slow ho jao because sir, 8 o'clock people will come, so at least they will have something to discuss. Na?
Okay, okay.
ठीक है sir. Thank
See, my experience is limited, so I have slightly on defensive side.
No, anyway, we have to be defensive only. Offensive तो होता ही नहीं है.
No, no, no. In the sense, I want, because the time limited, na. I thought crucial steps I will show.
So, when we start, sir, you start with the orientation of the
Yeah, yeah.
ports and the
Yeah, that video I have recorded 15 minutes, 10 minutes.
Acha.
That
So
will be played first, as far as my video is concerned.
Okay.
Do you think, see, once for my,
the professional work from you?
yeah, see, Ravi,
Yeah.
can you see?
I can see. I can see.
I have gone very deep.
Yeah.
I have gone very deep up to the almost like apex.
Okay, sir, we'll get back to you. We'll have a quick breakfast and 8 o'clock sharp we'll be here.
Okay, okay, okay.
Poor man, he's operating.
ఇవన్నీ చూపించకూడదు రాజా అదే మనం షుడ్ బి నీట్గా అయిపోయింది విల్ ప్రొసీడ్ నో ప్రాబ్లం వీ డోంట్ వాంట్ టు షో ఎనీబడి యాంటీర్ కొసేప్ చేసి ఆగేసేస్తాను ఎట్లా టైం అవుతుంది కదా విల్ ప్రొసీడ్ రామ్ little bit this I will drop. Dropping we can Udule Raja, don't get tempted. We are not that big persons. So, Bichama, Ramakrishna is saying stop here.
Yeah, I think at some stage you'll have to hold on, sir. But then you still have another 20 minutes for 8 o'clock.
Aim is not to show, aim is to finish properly, giving a proper message. Because a lot of time in the life is there to show. But going well, I am Anand.
Sir, you have a lot of time, sir. I don't have so much of time, sir. I'm 30 years older than you.
Hmm? అవును అనుకోవాలి కదా అది కంపల్సరీ నో వద్దు నాన్న here will see what is there already I have dropped too much. How to show this Emnath, you have to practice. Some people has to. I am taking for thumb.
That is just for the retraction, is it?
Yeah, this is for retraction. I keep it like this, it will stay back there. See,
Perfect.
that's all. Everything looks intact. Again, I will go here and show whatever the suction will be done. Come suction, and immediately we will show. Come suction. See, entire dissection is done up to more deeper. Anand,
Thank you, sir. See you soon in the hall, sir. Thank you. Yes, Dr. Chandra.
yeah, this part I was a little concerned, but I did well. See how almost up to the apex I have gone. See,
Yeah. Can you a little of a zoom in? Correct.
see, nine. Yeah,
Probably. Can we do a little bit of cleaning out there, sir? A gauze
yeah,
clean or something.
yeah. You will wash.
Yeah, we'll give it a wash.
Yeah. By the time you are ready, I will wash and show. Somebody retract this up. Yeah. Two suction should be there. Yeah, beautiful. Beautiful. We'll stop it here, Swami. So there will be something
We
to.
have Dr. Kishore watching you, sir.
Kishore is.
Hi, Dr. Chandra Mohan.
Hello, sir. Hello, sir.
So I'm the first one to join you, no?
Sir, I have dissected a little bit to take the time because 2 hours time was given.
Sure.
Naturally, I will be slow. So what I did is I have this is the vas, and this is the seminal vesicles on the right side, sir. This completely posteriorly, and this is the on the left side. This complete unit. So I have dissected up to the apex, like in
Posterior upper.
up to the apex, like in regius pairing type. So almost I have nothing to do here. Here. So now my camera was coming in the way. So I stopped it here and I started anteriorly. Now Ravi Mohan tell stop it there. So I am stopping it here. Now basically this I have mobilized. The, this I have mobilized. I am stopping it here.
Okay.
This I have mobilized. At the moment I am at the bladder neck here.
Okay.
So they said that stop. This I have to do like this. So I will go to the,
Perfect, yeah.
yeah. So now I have come up to this stage. So here the plane is there. This plane I will go. This is the,
Chandramohan sir, we'll keep watching you. We'll leave you on the audio for a few minutes.
yeah, yeah.
I'll just go to Dr. Mallikarjun, welcome him. And good morning, Dr. Mallikarjun, sir. Could you unmute yourself, please?
Bus.
Yeah, clear. Come, somebody keep it here, retract like this. Yes.
Dr. Chandra Mohan.
Yes, sir.
Yeah, so there are like 4 or 5 people have already come to the hall. So I think
Yes, sir.
yeah, so
Can we explain, sir, what we have done? Anand?
after it, yeah. So I have some questions for you, sir.
Yeah.
Like, do you feel like how do you comfortable? How are you comfortable with mantra? No, compared to the lab. Is
Uh,
there any learning curve to switching to
no, sir.
mantra?
See, sir, actually, when I started with renal cyst without much training. Because of the lab, little bit of experience, I felt it's okay if you understand. I am playing a 5 minutes video where how to use the arms. After that, I felt that there are only two things. One is clutch and camera. If you put the clutch, see, I am putting clutch, they are not moving. If I am removing clutch, they are moving like this. Camera front and back, front and back, both the instruments front and back. If you go like this, you will go so close so that you can see, sir, here. Are you getting my external view, sir?
Yes, we can.
See,
Yeah.
like this, I have so much close vision. See, I wanted to move like this. Here I will hold and retract. Slowly, I will, very slowly, I started doing. Then I realized that it is okay, not that much problem. Then the left I am putting, my hand is moving left. Now I am here. So I will pull it. And then slowly, this is the fat over the anterior abdominal wall. And this is all prostate. So this is a bladder. This is the prostate. So like that, back again, I am going back just to show the movements. See, this is the fascia. See, my movement is like this. I am turning like this. Slowly it is turned. So slowly I am moving. Control is there. Suddenly in lap it may go deep with the hook. It is not like that here. See, I am spreading like this slowly. Loose layer tissue has gone. This is the inferior pubic ramus. This is the fat. I need not separate the fat. See, now I am turning up like this. This is not there with the lap. See, this turning. If lap I have to do like this, then this will touch me. So then I cannot reach here. That If I turn like this, I can reach this fat, like this. See, like this, my hand is turning and then going all the way like this. I am removing the fat.
So you say for prostates, it's definitely a big advantage. I would say.
Sir, wherever I wanted to use this type of movement, this,
Okay.
if I can use like this movement, there is no use. For example, here, if I have to do something, this is the bladder, this is the junction. So if I have to touch like this, there is no use of the this thing. Only this it is useful here.
Got
Yeah.
it. Yeah.
So otherwise, for nephrectomy, definitely. See, I am reaching to the endopelvic fascia here. See, now my hand is turned here like this. Here in the lap, this will come in the view. That is the only thing. I am coming back like this. I am coming back slowly. I am coming back. I have done posterior completely. So because uh, uh, the time allocated is 2 hours, I thought I may not be able to finish fast. So I thought I will do initial dissection. So with the permission of the this thing, I have done it. Now I am going to the side. See, like this slowly. The movements are very sensitive. See, if you want millimeter, if you want to go close and do it, you can go close and do it. In fact, lap will not go this close. For example, this much I have done, this much I have done, then this much I have done. So unlikely that you will injure a major structure inadvertently unless you have missed it. See, now I am turning the prostate back like this. The posterior surface of the lateral surface of the prostate. This patient from here, for example, from here, I will make a fascia. This fat I will remove, and then if you want to incise on this like this here, lateral nerves will come from here, anterior also. Then I will sweep down like this, like this. So then I need not go to the endopelvic fascia at all. This endopelvic fascia I will not incise. Just I am separating so that it is easy later on. See, only separating. Normally we cut the endopelvic fascia here, but I am planning to cut here on the surface of the prostate. This fat I will remove. So here also, as per
Sir, Chandramohan sir,
yes sir, Ravi sir.
sir Ravi sir, nahi. You take a break for breakfast, sir, and then you come because by the time people join, they would have not seen. They would have seen only the anastomosis. The maza nahi aega.
Okay, okay, okay.
Maybe
Oh.
you can have a breakfast break because by the time people chip in would be around 8:30. So that would be the best time to showcase, huh?
Even this lateral dissection, no.
Yeah.
Oh.
Take break for a breakfast.
Okay, 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 okay.
Thank
Right.
you, sir.
Thank you. Dr. Malik sir, you want to talk to us? Babu, can you unmute Dr. Malik?
Good morning, sir. Good morning, Malik sir.
Hey, Ravi, I'll start off at 8 o'clock or not?
Hey, 8 o'clock. You start at 8 o'clock.
I've already started. I start my posterior dissection by the time you people join. That's what I was wondering.
Your choice. But I think, sir, yeah, fair enough. People will chip in at 8 o'clock. So we'll start sharp at 8. Chairman, sir, is also here. So we'll start sharp. Hi, sir. Morning.
Hi.
Bipolar पनिచేస్తుందా यार पनिచేస్తుంది यार bipolar थोड़ा कम करो यार बहुत ज्यादा है हेलो
Malik, Amit here. Hello. Hi.
Hi Amit, morning.
Yeah, slow down. You'll finish before anybody comes.
No.
Just slow down. There's nobody stopping me in the audience.
Okay.
It's a common problem of Malli. He finishes before things starts. Malli, good morning. All good?
Morning, good man. As usual, I'm troubling all your team guys here. They'll be cursing me after I leave.
So, if we talk with Chandramohan,
Yes, sir.
can we go to Chandramohan? Yeah, he's there. He's sitting there. There is Chandramohan.
Yes, sir.
Yeah. 1 minute. Unmute Pandya. Vijay, yaar patra? Unmute Dr. Chandramohan, please.
Retract.
Yes, Dr. Chandramohan, you're on.
Yes, sir. Sir,
Can you tell us about your system? Rather
Yes,
than
sir.
Surgery. Tell us something about the SSI.
yes, sir. I am showing here, sir. Am I visible externally, please, sir?
No, this is live. We have a recording that you sent us to be played when we are going.
Can you play Can you play?
No, hold on, Chandramohan sir. I think we'll do that at 8 o'clock. People are just
Okay,
coming in.
sir. Meanwhile, I will tell about the system as asked, sir. This is SSI mantra. We are using 4 arms. This is the hand control. When we put this leg clutch. This is a clutch one. Clutch one. Once you clutch, the nothing will move, and I am keeping inside. This is the neutral position. So when you wear the goggles, it is a open console system. When you wear the goggles, you will be seeing in the front like this. When you see in the front only, instruments will move. If you see side, it will not move. There is no neck pain.
Chandramohan, don't exhaust yourself. There are people are coming in, not yet seated. So we'll give you a signal when to give the instructions.
Oh, okay, sir. Okay, sir.
Just hang on a minute. Yeah.
Okay, sir.
Rajan, if they could just take the camera once and white balance it once more, Dr. Chandramohan.
Hello.
A little too much on the reddish side. If the camera can be once white balance, please.
White balance, you do it.
Yeah.
Anand, as Ravi Mohan told.
No, Dr. Amit Ghosh is here.
Yeah, sir is saying that wait for 5 minutes.
Yes, please relax.
Yes.
Yeah, I will have a cup of coffee and come back.
Chandra, yes, you have your breakfast first.
Yeah, no problem, sir. Thank you, sir. Thank you for the concern. మంచి చేసేసా మొత్తం ఈ అమ్మాయి దడ లాగించడం.
Peter, where is Peter? Yeah. When you send it to me, I'll send it. नहीं वो तो नहीं सर नहीं wrong sir you start at 8 o'clock undoubtedly sir ठीक है 2 जाने ठीक है चलो no right चलो
Mr. Anand, whenever permissible, we would first like to present the case from MPUH.
Yes, please hold on. They are just about to commence the proceedings. Please hold on.
Okay.
Yeah. Good morning, everybody. Welcome to Ahmedabad to the second annual Uro-Oncology Section Conference of the USI. I think it's been a hard task organizing a up-to-date scientific program. Believe me, it took us a long 6 months to prepare what we have done today. We have had debates about whether we should have an operating workshop or not. Ultimately, the dream came true. Our organizing secretary, Shanik Shah, supported us to the hilt regarding the operating workshop. And here we are, both with international and national faculty, with various types of robotics. And we are hoping to enjoy ourselves, both with the skills as well as the knowledge part of any conference. So it is basically, in one way, a hybrid. It is a workshop as well as a conference. And therefore, I hope we will all get updated on international standards. There is no point in trying to say that we are going to achieve international. So we are international benchmark now. And there are people, I tell you, the demand is rising. We have extended our knowledge base to Bangladesh. That is how we've opened our account. People want us to now liaise with them so that the knowledge and skill is shared internationally. So this all could have been done because you all responded amicably, appropriately to participate. And at sharp 8 o'clock today, we start this annual conference with the help of my counsel, Ravi Mohan and Ankur Mittal, and nothing less than very efficient organizing secretary, Shanik Shah. So thank you all for coming on time and letting us achieve this goal right on time. Thank you. Ravi?
Thank you. I think without much ado, we welcome you all for this great meeting. I want all of you to be interactive as much as you can. Any doubts you have, anyone, are welcome to ask on the two mics here, and we ensure that we just stick to time. With it, I hand it over to Ankur Mittal to invite the first set of chairpersons.
So I would only say today, and as usual, we'll stick to time. So please make sure that everybody, the all sessions, live surgery is already made on. All questions, we want to make it interactive. So somebody just ask how, where the ports have put. You can ask every question. There is no problem. And I am sure we have finance faculty who is going to reply to all questions. Thank you.
So good morning, everyone. So I think here we go. It will be a wonderful day ahead. So we'll be starting our first session that is on carcinoma prostate, and we have live surgeries here. 3 ORs will be there, and OR1 we will
On,
have
please.
RARP by Dr.
Ray Durgesh.
OR2 we have laparoscopic assisted radical prostatectomy. Dr. Malik is there. And OR3 we have again a robot assisted radical prostatectomy on mantra by Dr. Chandra. So I invite now, our chairpersons for these session. So may I request Dr. Janak Desai and Dr. Hemam Bakshi to be on the dais, please. May I request Dr. Shanisha sir, Dr. Amit Ghosh, Dr. Sanjay Agla, kindly join. So yeah, sure. Over to our chairperson, please.
Yeah. Thank you. Good morning, all. I think without wasting time, we'd like to go. Can we go to the Mihir, please?
You want to start off with Dr. Mihir? Okay. We are with Dr. Mihir. Or rather, Dr. Abhishek is there.
Hello.
Good morning, Dr. Mihir.
Good morning, everyone. Can you hear us?
Yeah, Mihir, we can hear you.
So one of our residents is going to be presenting the case to you. We
Is somebody
just about
retract?
begun 5 minutes ago, so I'm going to hand it over to them, and they will present.
This somebody retract
Can you
right hand, I'm saying.
Yes,
Yeah,
sir.
sure.
Okay.
Yeah, he's
The other instrument come.
gentleman, hypertensive. He came to us last year with complaints of blood.
Other
and
instrument
with, in
section
the
come.
form of incomplete wording, frequency, urgency.
You are
nocturnal
touching the
training.
camera, not me.
He had IPSS score of 16 and IAA score of 16. He did not have any family history of CA prostate.
No,
He
this
presented to
person
us
is not
again
correct. One who
that,
is coming.
PSA.
Yeah,
Upon
like that
examination,
suction
his
now.
abdomen was soft, non-tender, genitals were normal. DRE showed hard nodule in the
Acha,
right
wait.
side apex. This is the
Wait.
ultrasound showed
Wait.
normal findings. On investigations, his PSA was 10. Hemoglobin and all counts were normal. Creatinine was 0.8. Urine examination was normal. We got MPMRI done that showed right side apex lesion of 2 centimeter in pyrite 4 category. No other
Suction.
lymph nodes or bony met seen in MRI.
What?
Suction.
Then This was the truss finding we did in micro ultrasound, which showed 1.3 into 1.2
Keep on
centimeter
sucking.
lesion in
Saline
the
suck.
apex. The gland volume was 46 cc.
I will coagulate if anything
This
is
was
there.
the micro ultrasound
Yeah, there is one
finding
thing,
done on
coagulate.
29 megahertz machine, which showed a lesion in the correspondingly with the MRI findings. These are the histopath slides. We did biopsy, targeted biopsy mainly. 3 out of 7 cores were positive. Gleason 4+3, grade group 3. These are the histopath slides.
Raise the pressure.
Then we got
Raise the
PSA
pressure
medal,
for
which
a
was
while.
clear, which was negative
Devendra
for
sir.
any metastasis. Over to you, sir. Meher, sir.
Yeah, so as you can see, it's a grade
Suction
group 3
this.
disease, right apex, palpable disease, and on MRI, it is a fair-sized lesion. There is no clear-cut evidence of extracapsular extension.
Retract this.
So, what we
Retract
will do is his
bladder
baseline
bladder
SIM
collapse
score is
unda.
about 17. Moderately interested in preserving erectile function. So the idea is that we'll attempt to do a nerve sparing on the left side, but on the right side, where especially at the apex, we'll see how it goes, and then kind of maybe do a partial sparing there. It is a large lesion, and there is a correlation between the size of the primary lesion and the capsular kind of surface of contact as well as the probability of extracapsular extension. So what we've done so far is, I've just taken down some of the lateral adhesions. He had an appendectomy long time ago, so he had some adhesions from that. And I like to start with the node
Retract
dissection
this. Some
upfront.
one person
Most of
retract
the
this.
cases that we do nowadays are at least grade group 2, if not
One
higher.
person retract
And so
this.
if you were to use a nomogram, they would have all
That he is touching. Now you retract the
need
same, not
for a node dissection. So I
these
kind
two.
of routinely do it in most cases. And I do a template where, as you can see, we go from the bifurcation of the artery. I do not take out the lateral nodes. If you look at Studer's data, the chance of finding nodes there is very low. But what is more important is the nodes that are deep to the obturator artery and
This
along
is the
the
apex.
terminal branches of the
Yeah, I am
hypogastric.
reaching the
Those are the
pubic
nodes that you really
symphysis
want to take
inferior
out.
border.
And so
Can you see?
we will just clean this up a little
Swami?
bit here, and I'll do it on the other side. The reason for doing this first is I don't drop the bladder, as you can see, so the bladder is nicely suspended, and so I think the dissection is easier somewhat, and then I'm done with the case and the nodes when I'm fresh with the case, as opposed to having to do it when you're after the prostatectomy. But it's a personal preference. There is no hard
Can I touch
one
Emnath?
better than the other.
Can I touch here and do?
But as you can see here, we take out these little deep nodes that are along the terminal branches of the hypogastric. You can see we've bared out that's the obliterated umbilical, that is the obturator, and that is the superior vesicle. So those are all nice and cleaned out. So basically you want to take out the nodes underneath the obturator nerve. So it's taken us about 7-8 minutes to do the nodes on the left side. Now we will do the nodes on the right. I always start where the ureter crosses the iliac. So you can, on the right side, almost always see it even before you cut peritoneum. That's the ureter there. And from that point on, you open up the peritoneum along the artery. Here, part of this peritoneum is already open because he had adhesions with his terminal ileum from his appendix surgery many years ago. And then I use this medial flap as a retracting handle. So my assistant will come with a grasper through the lateral port and then hold this little edge of the peritoneum. And if you
Okay,
don't dissect
okay.
lateral to the or medial to the artery, you will always be able to roll the artery. The ureter when you reflect this. So that's the ureter there. You can see.
Mir Hemang here.
Find the
Mir?
yes.
Yes. So we were discussing, me and Dr. Hosh, when would you not do a lymphadenectomy, or do you always do a lymphadenectomy in all cases, or would you do only for high risk cases, or would you do it for intermediate as well?
So I like to do it for most of my cases now, but you could make a case if it's a grade group 2 disease and if the probability of finding a node according to say a Briganti nomogram is less than 5%, then you may avoid a node dissection there. There is now a strong case that is being made that, since the primary indication of doing a node dissection in prostate cancer is more for staging purposes than curative purposes, and given the advent of
I'm not able to proceed.
scanning,
Can you
probability of
take out
finding
the
nodes,
Caesar and put it again?
clinical node has gone up. You could say that if the PSMA is negative, I would avoid doing a node dissection. So that is certainly
We will proceed with the anterior, Swami. Time waste అయిపోతుంది.
I have no objections to it. But I do feel that, there are obviously all of us who do node dissections know that even in PSM in negative cases, you can find microscopic nodes. And so at least in the high yield area,
Take out that suction. Take out that suction. I am telling somebody, Swami.
As well as the terminal
It's instrument takeout which is coming in this end.
hypogastric. I feel that is well worth doing now. It adds about 20 minutes to the case. And these nodes, if they come back positive later on, are slightly more challenging to remove if surgery is an option. While nodes that recur, like say lateral to the artery or higher up, are actually fairly easy to remove if you have to. One of the treatments being explored for node has been started or detected. So people have but I do like to take out the high yield ones that are going to be difficult to take out this class. So maybe we will keep watching you. Can we go to the Monday? Hello? Yeah, Monday, good morning. Good morning, morning. Actually, the MRI showed that there was a hole in the area, the iliac area. So I just saw that hole here. I just taken it out and possibly I get hole. The left side where the nodes are there. But anyway, rest of the thing, then I proceed with the prostatectomy. And if time permits, I'll go on to the left, the right side is over there. So trying to not be perpendicular. I want to scale it sometime. Malik, how much often we get a case history from what
Durgesh.
Can we have a case history, please?
This. Scissor is removed again. Why voice is not coming to our theater from Anand? ఆడియో ఇక్కడ షేర్ అవ్వట్లేదు.
Just now have a quick discussion with me. Now I want to ask you, why do you do lymph node dissection at all in this case?
I have stopped doing an extensive node dissection of late in CA prostate.
So you don't do it as a matter of routine.
Okay.
I do it whenever it's indicated, but I don't really look into a extensive node dissection. Was what I was doing once upon a time so few years ago.
Okay.
Possibly the PSMA scan has changed our
Exactly.
perspective.
That is the point.
Basic
I mean,
crux of it.
you're not actually doing any therapeutic good to it. Instead, you're taking a longer time, more anesthesia, more complications, and
Artery.
not actually increasing the lifespan of the patient, and you're not doing anything to the disease at all. And you have options. If suppose it comes up as positive in a later date, you do have other options. So that's why I wanted to know your philosophy.
No, that's what I said. I think there is a slow change in our whole thought process regarding the amount of node dissection anybody is doing. You see, even now, once upon a time, if you know the dissection, the whole thing was completely getting barren. Nowadays, I don't do that sort of a dissection. I just do whatever I feel. You see, there are two nodes which I thought is very significantly positive, which I thought I'll take it off. And then I don't barren the area or something like that, which I used to do before. But other than that, in CA, we have a different opinion when it comes to CA bladder, where we do it in a different perspective at all, completely.
Yeah, Malli, we'll keep watching you. Can we go to the Chandra one or?
Have a video recording of the initial steps. We'll go straight live. Go live.
Go live.
1, 2, 3.
Yeah, live. Yeah.
Dr. Chandramohan?
Yes.
Yeah, Chandramohan.
Yes, sir. Sir, good
morning. Can someone present your case, or can you?
Yes, sir. The video I made the presentation, sir. Can Anand play that?
Yeah, if you can just tell us in brief about what's the glycine and what's the PSA and what's the size.
Sir, 3 plus 3, 35 grams prostate with 3 nodules, preferably on the anterior lateral peripheral zone. One at the mid right, one the right left, and then one nearer to the apex. So it is totally confined to the prostate, but otherwise bilateral T2, C, intermediate to high risk. Otherwise, the posterior part completely free. Biopsy done once. After 6 months, I have again biopsy done by us and proved 14 crores positive. So 14 crores and 20 makes it high risk. So we are trying to do posteriorly because it is completely free. We try to do nerve sparing. At the moment, I am using SSI mantra. Are you live with me, sir?
Yeah, we are hearing,
Sir,
seeing you both.
Yeah, sir. So the movements are front and back camera, open console system. Now I have the fourth arm here on the side of me. Whenever you wanted to see, that fourth arm should be seen and then activate. Now, for example, I have started a little early. Now they are retracting. Can you put the fourth arm into my view? Yeah, is the fourth arm view. So then only I can toggle. Once it is in view, I pinch it. It will toggle and then it will come. I will go as low as possible like this. Under vision, my camera. Now I am retracting the posterior. First I did posterior. So I am making it straight and retracting. Now I will toggle again. It will stay back there. Now my right hand instrument will come into picture now. I will go inside in the center. This is my right cord and seminal vesicle. I have not used any. I have used clip in fact. This is the seminal vesicle and this is the left side cord cut. This is the seminal vesicle and cord. Both together, if I hold like this, then entire posterior I have gone up to the apex. I am able to see my camera can go deep inside like this with good vision. See now I will retract the bladder base above so that you can see how far I have gone. See now this is the picture. This is the picture. This is the Denelfeller's fascia. I have not seen any fat here and I have gone the anteriorly. I have not dissected much. See, this is the anterior. I can cut like this and dissect, which I don't want. Later on, I can pull and do it. This is the plane between the bladder and the seminal vesicle. This is the cord of the right side. Yes, sir.
Chandramohan, Amit here. Just a request from the audience. We wanted to know what ports you have made. And,
Yes, sir. Anand,
about the machine also. I
Anand,
know you are operating inside.
Anand,
But I think there is curiosity about your machine and your ports.
yes, sir. Anand, please, can you play the ports which I have placed?
Yes, sir. We are going to play the video that you have sent us.
All the system, how it works.
Right.
respected chairpersons and my dear seniors, I first of all thank the Uro-Onco USA Society for giving me this opportunity to demonstrate robotic assisted radical prostatectomy today. In first, I will present the case. This. So this is the robotic
Police balloon removed.
prostatectomy with bilateral PL index. Seminal vesicles are free. Pattern 4 to 5%. 25 cores are involved. LB with this, this is a theater of around 20 by 20 prostate and Foley's catheter during the surgery. Assistants will have 2 ports, one on either side of the camera port. This is the camera port, so right, left camera ports, 2 persons will be there. I am expecting Dr. Siddhalinga Swami and Dr. Hemnath will be assisting with suction and the hemorrhagic clip applicators. One is 10 mm, another is 5 mm. So total we have 6 ports. The camera port is 12 mm. The other robotic ports are 8 mm and one 10 mm regular port, one 5 mm regular port. This is done. Now we will do the docking. In this docking, we are showing the live so that how much time it will take, it will take. The engineer as well as the urologist will both do the docking. Now, please, a lot of people say that it will take half an hour. Not necessarily. You can take in 5 minutes average time. Undocking time is 2 to 3 minutes. So whenever there is emergency, undocking time is 2 to 3 minutes. So with this, we will proceed with surgery. My plan of the surgery today is the doing of the bilateral lymphadenectomy, doing of the posterior first, lift the seminal vesicles, try to spare the nerves, and use cold clipping at the seminal vesicles, and then after that drop the bladder.
Use the neck.
Then bladder neck you do complete.
Why you are telling like that?
Cutting of
I am
the
clear.
muscle. After that, go laterally over the prostate.
Okay, right. Thank you. I thought I am doing wrong.
So to the audience, we are presenting same surgery, radical prostatectomy by 3 different Robo. One is Da Vinci, which Mihir is doing. Second, SS Mantra, this Chandra Mohan. And third, man himself is a robot, Mallikarjun. So we'll have an opportunity to see that all the 3 different surgeries by 3 different methods. Please, over to Mihir, please. Yeah.
No, I don't want to remove. That is what I want to show. This fat I want to separate like this and keep it.
Yeah, Mihir, go ahead.
So what we've done is we finished the nodes on both sides. I totally agree with the discussion on the node dissection that was had. It is less relevant in prostate cancer than it is in bladder, and hopefully I'll show in my
This is the latest technique that fat we don't remove.
doing an extended node dissection is now there are level 1 evidence to show that it doesn't improve survival by going all the way up to the aortic bifurcation.
You understand, Hemnath?
So now I've dropped the bladder. I don't open the endopelvic stretcher right away. He has accessory pudendal arteries that we try to preserve. And I don't do an aggressive bladder neck sparing, but I just try to create a little groove on either side of where I think the bladder neck is, so that we don't make an unduly large bladder neck. So that's at least my philosophy. I think again there the jury is out. I don't think there is any substantial evidence to show.
Just a minute, Mihir. We've got a question from the audience. Yeah.
Question for Dr. Mihir Desai. Fourth arm on the right side or left side? Your preferences?
I prefer to have it on the right side, and the reason being, this allows me, I'm a right-handed surgeon, I have a grasping instrument in my left, and this way I can have a grasper in both the right and the left hand. If I need to move bowel away, if I need to, move things away. So that's my personal preference. But I know people have done it both ways, where you can leave it on.
Just ask whether our transmission is there or not.
I prefer to have it on the right side. Now, once we get and see the catheter, I will basically drop this down. I don't do any more dissection till I get the catheter up on the traction.
On the screen, it is there or not?
Has deflated the Foley balloon. I will remove it. I will lock it into my 4th arm. Go all the way.
I am not convinced or not.
Lock that in place, and then the assistant gives traction on the catheter. And then I just like to move the bladder neck with my left hand only.
Purposefully, because initially I thought, okay, I got the point what you are telling.
Release the lateral part of the bladder. Try not to go onto the posterior bladder neck right away. Till you drop the lateral part, that will make the posterior bladder neck dissection easier. And I kind of see what thickness I want to have and basically go into that groove. It's the groove between where the bladder reflects onto the prostate base. And then as you go medially,
Three screens ఉన్నాయా?
bit of the apex of the mucosa, but again, I'm just releasing, and have this whole thing down. So what was once up like this has now come down on this side. I do the same thing there on the other side. I will look at the whole bladder neck there. This is my mucosal incision. And then when I pull, I find where that groove is between the bladder and the prostate base. Keep getting this mucosa down. Try not to go inward, otherwise you'll head into the prostate base. You want to reflect this down, and then you have very good exposure to look at the posterior mucosa. Now, see, the posterior mucosa is seen very easily. The urethral orifices are going to be down there somewhere. You don't need to see them unless you have a very unusual bladder neck like post-party, etc., where you want to really see where they are. And then I kind of identify a thickness for myself. I'm not having the assistant do any retraction, and I'm not even grabbing the posterior bladder neck. I see exactly where I need to go. And then once I have a certain depth of the bladder neck, I will open and close my left hand. See that? And so you see the denominator fascia there. Once I see the denominator fascia, I don't go again for that directly. I first release the bladder neck more laterally, release it more laterally. And then once I have this exposure, I just go straight in. That's the anterior lip of denominator fascia until I see the prerectal fat. That's the prerectal fat.
Yeah, Dr. Meher, Ravi, this side, great dissection. One of the major learning curves at this step would be to reach in the right plane.
Correct.
Would you like to describe for the audience what is that and how you do it?
No, absolutely. So as I was saying, to me, the guide is looking at the posterior mucosa. When I see the mucosa here, I see a thickness here. I make my sure that I'm at an appropriate thickness, but parallel to the mucosa. I'm not going like that, where I'm hitting the bladder base, or going too acute, where I'm going to buttonhole the bladder. So that a judgment of the thickness and the plane which parallels the mucosa is very important. The other thing you can use when you're starting off your journey is to do the posterior dissection first. You can go behind, dissect out the SVs and VAS, so you have something to aim for. So that's also something that, you don't need it with experience, but if you're early on, I think, and sometimes in difficult situations, like, for example, if I know there is a giant median lobe, or if I know that there is a salvage case post-radiation, then I sometimes will dissect posteriorly first.
Yeah, because median lobe is another problem which you encounter if you just a large median lobe, right?
Yeah, so the median lobe, what I did by doing the lateral bladder neck dissection, that part becomes even more critical with the median lobe. If you dissect nicely laterally, then it is easier to deliver the median lobe from the bladder itself, and then your dissection becomes easy. In fact, in my mind, the more challenging situation is intravesical lateral lobes. Those are actually more tricky than a large median lobe, which is symmetric and central. So now I have taken down these diffuser fillers. As you can see, I have a nice and wide exposure of the SV. I have not even gone to dissect out the VAS and SV. So that's another mistake. Once you see it, don't immediately go for it. Now I lift it up, and now this is my trick for the SV dissection. This is the anterior surface of the VAS that is facing me, the medial surface. That's the only two parts of the VAS that I will dissect. I will not go lateral here. And I will leave the VAS attached to the seminal vesicle, so that if I pull on or lift the VAS, I'm lifting the seminal vesicle with it. So once I have this anterior and medial VAS there, then I use the fourth arm. I'm not just retracting upwards. I'm pulling, it's almost like I'm pulling the pelvis, the prostate out of the pelvis, and then I evert it because I'm interested in the medial part. So see this tissue? I just pull it, and it will take you directly into this nice space between the SV and the denominator fascia. And if I dissect like this, it automatically dissects the SV nicely. See that?
Great
And to
tips.
get the tip of the SV out, try not to go for the SV directly. Basically, what I will do is I will lift the VAS out more. So I just hold the VAS a little lower, pull it up more, and that automatically lifts the SV with it because I've kept the vase attached to the SV.
And what cartridge setting are you using, sir?
Laterally. So now once you see the tip of the SV, this is the tip of the SV. Now the job of the vase is done. All I do is go behind it and I cut it cold. You don't need to clip it. You don't need to burn it. Just cut it cold. It's fine.
Yeah. Mihir, will keep.
Lift
Yeah,
the SV up and then a couple of flips and you should be able to take the entire vas deferens vasculature with you. So this is the
Mihir will keep watching you. Can we go to the Malli, please?
Yeah, before that, a request to all presenters for the next sessions to come and load your presentations, please.
Yeah, after the live session, there are talks, so kindly give your talks to the Anand, so we go on uninterruptedly. Please, can we go to the Malli, please? Yeah, Malli.
Babu, unmute.
Yeah, I think I finished my posterior dissection already now, and my seminal vesicles, everything is empty. Sorry, they are mobilized. The problem here is a large prostate and a large median lobe, so I cannot go further into the dissection into the back, and my restrictions with my laparoscopic this thing, so I can't go beyond this. So I'm just stopping it here. I've dissected the seminal vesicle, so I stop here and drop the bladder now.
I think your image is frozen.
My own thing.
Just hold on, Dr. Malik.
Oh, shit. What happened, Anand?
Yeah, Malli, now we can see.
Okay, right. So I always say when we need to drop the bladder, either we go to the midline and come out, but my feeling is always go to a place where there is a peritoneal reflection which happens on the lateral wall, and that is the right area. Just divide this area, there is a reflection which happens and it opens up. It opens up easily. And you will be able to see the actual plane between the peritoneal, the fat into the anterior abdominal wall and the fat on the bladder. So most of the time we end up in the initial beginning stages, we end up in taking out this fat along with the bladder, which is not necessary. So taking that cue, you just dividing that peritoneum next to that abdominal wall will give you that plane opening up, which is very well open. That's how. So you need to be sure that you are not taking the abdominal wall fat along with you. That is unnecessary and that creates more amount of bleeding. And all the peritoneal incisions has to go right up to the area of the internal ring, which makes it easy for the bladder to drop in. So that is one small technique which I always advise the people to say. And there is a nice plane between the two. There is never an adhesion between the two. There's a nice plane between the two. So beware that you'll be doing it between the abdominal layers and the bladder layers. I'm clear, I hope.
Malli, can you just show us your posterior dissection, your technique, or at least principally, how do you do the SVs? How do you handle that?
Much difference. I held the peritoneum here. I don't mobilize the seminal vesicles. I go as low as possible and then drop the seminal vesicles. Never try to dissect the seminal vesicles ahead itself. Go as low as possible and then take out the seminal vesicles. That's my principle.
Okay.
So having done that and having created that plane, I know where exactly I stay here now. So I start dividing that area.
Okay. Anand, can we go to Chandraman?
No problem. Here we can open. Okay, keep police move.
Yeah, Dr. Chandraman, we are with you.
Yes, sir. Sir, posterior dissection, should I show one, sir? I have dissected the bladder neck here. Here. Are you able to see the live, sir?
Yeah, we
on either side. So basically,
do you have the white balance? Is the colors are looking little artificial? Is it possible that you do little white balancing kind of a thing in your SSI mantra? Because
suction. Yeah. Suction. I will do it, sir. Can you take out the camera and do the white balance, please?
Please.
Yeah, take it out and do it.
Mihir, we are with you.
Okay. So as you saw, I did the seminal vesicle.
Local and open చేసేస్తాను.
One of the things I like to do.
Clean.
I'm sorry. Just Dr. Mihir, you're on.
Hemnath, right hand also clean.
Mihir, yeah, go ahead.
స్వామి
I'm just saying that I have
నేను కట్ చేసిన చోట కట్ చేస్తే ఓపెన్ అవ్వదంటావా?
assistant. So if you spread it, that
Huh?
really spreads the posterior denominator fracture nicely. And I
ఏం లేదు.
the thing. So what I like to
మరి
do is
మీకు అది వస్తే సరిపోతుంది కదా, ఎక్కడైనా తినే ఉంది.
then correct
నా తర్వాత నేను మార్చుకోవచ్చు.
the fracture plane. Okay.
మళ్ళీ ఇప్పుడు కొత్త ప్లేన్ డివైడ్ చేస్తే గలీజ్ ఉంటుంది.
About
ఏం రా
30-degree telescope.
కానీ మరి త్వరగా నేను చేసేస్తాను, వాళ్ళు వచ్చే లోపల ట్రాన్స్మిషన్.
To a 30 up view, which allows me to dissect
ట్రాన్స్మిషన్ సరిగా లేదా?
all the way behind very nicely. You can see the view now.
వైట్ బ్యాలెన్స్ చేసేసుకో.
And this actually gives you a very
కానీ నన్ను ఇంకా టైం వేస్ట్ చేయకూడదు మనము.
and the assistant will push the rectum.
హేమ్నాథ్ కమాన్, నౌ దిస్ ఈస్ అ టైమ్ యూ హ్యావ్ టు బి అర్. ఇప్పుడు దాకా నేను చెప్పలేదు.
And my left hand is giving counter traction above, and then I can go laterally.
హాట్ వాటర్ में लगा के करो ना जल्दी.
From this posterior.
White balance करो प्लीज स्वामी.
As you know,
And I have to open that bladder neck.
on the right apex, so that's my area of concern. But left side seems fairly benign, so the left side is where you can start. Can you see the bundle here? That's the neurovascular.
ఎంత వస్తే అంత, మనది అంత ప్రాపర్ గా రాదులే, లైట్ తీసుకో.
And you can actually start the plane of dissection between the two. So
విజన్ అంత సరిగా లేదు.
I do an antegrade approach, but I can
సక్షన్ చేసేసి ఇక్కడ వచ్చేసి. హేమ్నాథ్ నువ్వు ఇట్లా చేయొద్దు రాదు హేమ్నాథ్. సక్షన్ చేసేసి బ్లాడర్ ని ఓపెన్ చేయాలి త్వరగా ప్లీజ్. మళ్ళీ మనకు మైకి ఇచ్చే లోపల బ్లాడర్ ని ఓపెన్ చేయాలి.
But this posterior dissection is greatly facilitated by a 30-degree up view.
ఏది యూట్యూబ్.
As you can see here. If you are using any thermal energy here, it should be very point specific and not too much. This is always a perfect
Come.
here.
Suction.
Begin the nerve bundle release all the way.
Swami, suction please. Police catheter move.
Don't worry, don't try to get too much of
Police catheter balloon inflate చేసి కొంచెం అక్కడ వస్తా ఉంది కదా, క్లోజ్ అవుతుంది కదా స్వామి.
Yes, very well.
Suction please. Saline.
So that's my landing spot now.
Will you go as far as the endopelvic fascia here right now?
Sorry?
Will you aim to reach the endopelvic
ఇక్కడ
fascia?
ఓపెన్ చేస్తాను, నన్ను కన్ఫ్యూజ్ చేయకుండా నాన్న.
Once I find this groove, then it gives me a target to aim for with my antegrade approach. And then once I release a bit of the pedicle, it becomes easy. I don't try to do it completely here. Till wherever it takes me.
Am I going correct or not, Swami?
So normally you prefer to go right up to apex, the posterior dissection from the
If possible, yes.
Yeah,
the more
yeah.
now the better it is. So now once this is
పోలీస్
done,
catheter ఉందా లేదా రా నాయన?
a 30-degree down view. The 30-degree up view is good for dissecting, but it is
Suction,
not good
please.
for clipping. Because the assistants.
This is bladder fibers only, na, Swami?
So it's very hard on the assistant to clip in a 30 up view. So now I have that groove created. So I know now where my prostate base is. So I know
urethra అయిపోయిందా ఏంది?
put my clips for a nerve clearing. Wet clip. And this tissue, even though it may seem innocuous, these things will have.
ఏరా కన్ఫ్యూజన్ అవుతుంది స్వామి. urethra అయిపోయింది.
I just like to keep the view very clean.
కేథెటర్ లేదా?
But now I can basically just follow this.
చేసేనా?
Exactly where my clips need to go. So I have not
ఏం నా?
opened the endopelvic fascia here
ఇదేంటిది?
because I think the nerve sparing is done a little better with the. Can you put a clip here at that level? Lower down, just hit it. Because if you open up the endopelvic fascia at the beginning,
Am I doing correct, Swami?
Dissecting lateral to the neurovascular bundle also, which you don't want to do.
Hemnath,
To dissect the neurovascular bundle, the easier it is. So now
am I doing correct? I have literally subtrigonal పోతున్నానా అని.
If you do it at the beginning, you end up opening it here, which is outside the neurovascular bundle.
కేథెటర్ లోపల పాస్ చేయరా నాయన.
So that automatically shows me now the level at which my clips need to go.
You retract this.
Yeah, hit it.
Yeah, can we go back to Chandra? He's doing an important dissection. Can we go back to him? Yeah, Chandramohan, you are doing we are with you.
Yes, sir. I just opened the bladder neck. I was little away.
Yes. Yeah, no, we can see very well. Yes.
Withdraw the catheter. Fourth arm I will use. Withdraw the catheter, please. Balloon deflate. Balloon deflate. Can you take the fourth arm, please? Okay, sir. I am going back. Fourth arm. Toggle. Hold it. Okay. Toggle.
Dr. Chandra, do you have any of the engineers of Mantra with you?
Anand, should I tell one thing?
No, we just want the color to be a little bit.
It will not change, Anand. This is the problem with this mantra. So color will not be that good. The white balancing is done. So I am going ahead only near the prostatic region. You are able to see something or not?
No, we are able to see. Chandra, it is reasonable. No.
Yeah, if it is reasonable, then we cannot improve more than that. We are facing problem regularly also. That's why I am not see. Posteriorly, I have already done. I am planning. I have not removed the fat over the endophilic fascia. I have not cut the this thing. So directly, I am going posteriorly. So close to the bladder. So laterally, I will not go. Once I take out the seminal vesicle, then here is the trick. I have to be careful. So I have made a. So now this tissue undermining should not be done. This is the last crucial part for me. So I have to go to the area where I have dissected already.
Yeah, Chandra, it is now seen much better. We will keep watching you. Can we go to Mallikarjun?
Yes, sir. We are going to Dr. Malik.
Yeah. Shrenik?
Yeah, Malik.
Yeah, I think you saw me doing. What did I do? I opened up the two layers of the endophilic fascia. One layer going towards the lateral aspect. One layer is still covering onto the veins there here. And what I did is I separated it off there, and then I started dissecting the prostatic pedicle. I am on the side of the bladder.
Here we have to
prostato vesicle junction, and I am trying to create a plane, and that is bladder. I think bladder. I went into the bladder again. Okay, doesn't matter. I'm trying to separate this prostatic pedicle away from the bladder. We'll drop the.
Okay, can we go back to Mihir, please?
Yeah.
Sir, can I ask a question to Mihir, sir, please?
remove the suction. Why are you keeping it?
Mihir, sir.
I want to enter the posterior.
At this point of time, what is your take
Suction.
on high anterior release as the way Vipul Patel sir does? The way you are doing antegrade dissection right now, do you find retrograde dissection of high anterior release a bit more convincing, or what is your take on that, please?
I think, see, the idea for a nurse
Not the way you are suction. That is the whole.
that gets into
Or I should go here.
capsule and the neurovascular bundle, right? So
Yeah.
if you can do it
Swami.
effectively retrograde, that will give you the same result. If you can do it effectively antegrade, it will give you the same result. But can you see this now? That's the capsule of the prostate.
Kajjalanka.
That's the neurovascular
Huh?
bundle. There is no tethering. There is no adhesion. It's a nice, clean, look. I have not gone subcapsular. So now what I do is I'll come in here. But if you did retrograde, you would basically get into the same space here and then peel backward.
Yeah.
I find
Should I
it
cut?
easier and more consistent to get into the correct space from the antegrade approach. But there are people who do it very well retrograde, so no complaints there. But now look at this. If I had opened the endopelvic fascia, I would have made that incision here, correct?
Yeah.
I would have dissected outside the neurovascular bundle. Right now, the only dissection that I have done is between the prostate capsule and the neurovascular bundle. The lateral part is completely intact. So from a post-operative,
Can I go here lateral?
scarring, traction injury, etc., the risk of
Can I extend?
any such thing is low. So I will now keep doing this. But do you see how easily the bundle is peeling off?
Yeah, it's well.
And you can see a nice clean capsule here. So That is your key for nerve sparing. So always take the perforating vessel. One of the reasons why you get capsulotomies in nerve sparing is if you try to tease off these perforating vessels, they take you into a subcapsular space. Now I'm going to stop here because we'll start getting into the some of the lateral aspect of the DVC. And since I still have to do the other side, I don't want to be committing myself to that at present. I will cut it cold and I will release the apical part of the nerve once I'm there. But I just wanted to show you the prostate here, nice and clean there, and that's your nerve bundle completely preserved.
Mihir sir, uh, so you showed a very nice dissection, but I think one of the reasons why in the earlier times we used to cut the endopelvic fascia was to also know, even if you have to preserve the nerve, you know that this is the tissue which you need to preserve to do a proper nerve preserving. So do you recommend that when you start your
I don't. I have not opened endopelvic fascia in the last 6 years in any of my nerve sparing. But if
in
you're
your
doing a non-nerve sparing, or if it's a very small prostate, where you don't really get a good sense of where the contour of the prostate is, by all means. But I do feel that you are increasing the amount of dissection of the nerve bundle and risk of potential risk of post-operative
వెయిట్ ఏం
scarring
నా
and all
తీపి
that.
బయటకు వచ్చేస్తే
Traction injury to the nerve.
వెయిట్ నన్ను
So
కన్ఫ్యూజ్
here
చేయదు
I'm
నాన్న.
going to be going a little more carefully. This is the side of the tumor. I won't go like a complete wide resection because there is no clinical evidence of extracapsular extension, but my threshold for going wide is going to be low, and I may not do as high a release on this side like I did on the other side. So you can always tailor it and do a partial nerve sparing. I do feel that doing a nerve sparing in some way does impact continence. I don't think the nerve bundles themselves have anything to do with sphincter control. It is just that if you are in this correct plane, you hit the urethra at a very appropriate spot, as opposed to if you were, as opposed to if you were doing a non-nerve sparing and you go wide, you end up like dissecting lateral to the urethra.
ఇటువైపుకి రావాలా రెండు వచ్చేసినాయా?
Get a higher degree of incontinence. It's not anything to do with
లెఫ్ట్ సైడ్ వచ్చింది.
but just the tissue plane you're at. So if I can get a nice tissue plane going here like we have on the other side, then I think doing a nerve sparing, even if it's a partial nerve sparing on this side, also might help. What?
and how do you ensure that you're not entered into positive margin on the side of it?
You can't ensure, but if you see the tissue planes, I hope to be able to show you. If it is stuck, if it is not coming off easily, then you go wide. You don't push to get a nerve sparing done. But look at this. So this is plane here is opening up well. See that?
Yeah.
It's your nerve sparing plane. Okay. It is clean. There is no
Okay,
adhesion.
Amnath.
Nothing looks hard. I cut cold. One of the benefits also of cutting cold with the scissors is that you get a feel of the tissue. Even though there is no direct haptic feedback, you do get a little bit of a visual cue as to how that tissue is cutting, how does it look. But here, at least at the base, we know he
What
doesn't
is
have
this?
any disease. So we can be more, okay with staying in this plane. But just see the nature of this tissue here. See that?
Yeah.
It's coming off very, very nicely. And so I will stay in this plane. At any point, if I feel, oh, this looks hard, this looks stuck, it's not coming off the capsule, I just go one layer outside. I don't persist with it. So my threshold for going wide is going to be much lower at the site of known PIRAD 4-5 disease or site of higher grade biopsy.
We'll do this type, this side.
Now that I've released this part, now my direction of retraction will change. Instead of retracting,
Can I cut this?
I will retract like this. My left hand goes underneath the prostate, and my right hand goes above the prostate, and this way I can manage flashing. But now see, I'm going to open up endopelvic fascia here. This is where it opens up. That's the neurovascular bundle. Okay, so you do it. So the one key thing in nerve sparing
is
to slow it down. Okay, you cannot rush through this part of the operation. Slow it down, do it layer by layer. I'm not making any big move. I'm just exploring gently. And then try to push the prostate away from the bundle as opposed to the bundle away from the prostate. Not always possible. So wherever you can, try to do that. Now I'm coming near the apex, right? So now here, I want to be a little careful. So I want to just check and see how this area looks like. I think I'm going to go a little wider here. Slightly, one
Okay.
here. Now that tissue looks a little suspicious to me. It's a vessel here.
Come on.
I'm going to go a little wider here. I'm going to go wider here. That's a thrombosed vessel. See that? It's a vein, thrombosed vein. So I'm going to leave that vein with
Take
the
it out.
apex, so that gives me an extra layer of security. There's no neurovascular bundles in veins.
Take it out.
Mainly follow the arteries. But that's the kind of tailoring you can do just to give yourself a few more millimeters there.
అక్కడ వాయిస్ చూడండి అన్న మనకు వచ్చినప్పుడు రావాలి.
Extra capsular disease there. Now, once that is done, now I go towards my apical dissection. So we will show that. I will cut the DVC cold and then we will undersew it. So what I do is, I
Wait,
hold
Hemnath.
prostate at the bladder
Left
neck
hand
at the
grasper is
top,
not holding properly.
the catheter all the way in. And now I'm going to finish the nerve release on this side. See how much higher I am with the nerve release on the left compared to the right, because this is a side of no disease. And now I will go straight into dividing the DVC. Now the key in dividing the DVC is to first come
Okay.
from the
Do
lateral
it.
side.
This is
So
the
I'll show you where in the midline to go. If I cut directly here, I don't know whether I should go there or there. But if I follow the apex
section,
on both the sides, it will lead me to the appropriate
section,
portion in the midline.
section, continue
So
section,
I start laterally on both the sides.
continue section.
I'm cutting cold. There is no these arteries. There will be a few pulsatile arteries that you have to surprise. Don't worry about the veins. The veins, once you divide both the walls, will collapse. I use air seal at my place, so that actually gives a little more, pneumo support. But this is also working well, so I have no problem here. You buy a little bit of oozing while
Right.
you get through it, but again, don't rush through this part either. To me, this gives you the best chance of minimizing an apical positive margin. If need be, as Dr. Abhishek is doing beautifully, he's giving me a slow drip of irrigation from the top. So I can at least get my visibility. You can see that the veins are all open, yet I'm able to see enough.
Continue section, continue.
And in a second, you're going to see the urethra.
The left hand instrument is not working.
Otherwise, it'll keep suturing, it'll bleed again.
Left hand instrument is not working. This is not holding.
Before you start your.
I am feeling uncomfortable.
So now I'm beginning to see the urethral notch here. That's what you want to see. It's a loose tissue in the midline.
Mir, will you increase the the pressure in the abdominal cavity when you are doing this?
Suction.
I have not generally, but you could if you feel that the venous oozing is.
Can I cut
more.
this?
One of the other things that also is a factor, and I don't know how many people use it here, but if you use intermittent compression pneumatic stocking, those also
Leave it.
increase the venous return from the lower extremity and sometimes can cause the bleeding to be more. So now remember, we didn't complete the nerve
Suction,
sparing,
please.
on the apex on this side.
Hemnath clip.
Because I didn't want to get into the DVC, but now that we are
Hemnath
here,
clip.
I'm going to release that. Release that.
Below.
Release that.
Yeah. अरे हेमनाथ
There's
क्या
a
हो
little
रहा है रे?
perforator here. You can see. The apex always has some perforators. Release those before you.
Clip it. Suction, Swami. Suction. Come on.
Capsulotomy.
Minute to minute,
See,
you
I'm
have
not
to do
asking the
suction.
assistant to retract anything here.
Come on, Swami. Where are you?
If your retraction is good with the fourth arm in your left hand, you will find.
गंदा लगेगा यार ऐसा करे ऐसे please. ఎందుకు clips పడట్లేదు?
So
Think
now,
about it.
with that done, now the urethra is almost dissected. I just have to do a little more dissection paraurethral here. And then what I will do is I will take either a V-lock or a Stratafix or whatever you have as your braided suture to suture the DVC. It's important to suture the DVC before you inject the urethra, because once the urethra retracts underneath, you don't get a good sense of what your bites in.
Suction చేస్తే కదా స్వామి నువ్వు.
Only one. And whatever braided state. So do you see those veins there? That's the only part you need to suture.
కట్
So
చేసేస్తాను
start
నా
from
వల్ల
one
కావట్లేదు
side,
ఇంకా.
up and down, stitch. This keeps the anatomy nice and pristine and it doesn't bunch up tissue. This is why I like to suture the DVC afterwards. I can only suture the veins that are
It's over.
bleeding.
Okay.
It's a good statement that Mihir, you said before cutting the
Who is
urethra,
doing
you
that?
suture
What
it.
are you doing?
So you
Why
are
are you poking that
You
into
know
the?
that once the
Huh?
urethra retracts, it's difficult to know, and sometimes you can take
very,
two
Yes.
yeah,
and
yeah.
include urethra in it.
Very, very valid point. Very nice.
Why it is coming? Chalo, other side we will go.
So again, you know, the key to keeping this procedure fast and efficient is not necessarily to rush things, but in fact to do it nice and carefully, so you're not repeating any step. Everything is done meticulously.
Okay, Mihir, we'll keep watching you. Can we go back to Malli? Malli.
Thank you.
Yeah, Malli, we are with you.
Thank you, I said. Oh God.
Huge median lobe for you. It's
Hey,
Section.
catheter out, please.
So, what is the trick for median lobe? Malli, please.
I'm just trying to
Uplift.
make a
Yeah, okay.
Second cut.
So you uplift with sutures. That's right.
I'm just trying to get a fraction
Can I
of
cut
the
here?
median lobe so that I can get
Correct.
it
Okay,
back.
okay. No, that's
See, there are three, four things. This gland is very big.
Huh?
Yeah.
For 180 grams. Not a
Should I cut close to prostate?
well, it is not a idealistic scenario for any
Section.
Malak.
Is the prostate?
Looking at the surgeon, the case is selected. Malli, yeah.
No. I asked you, Zala.
Okay.
You deceived me. Even needle load.
Anyway, Malli, we'll keep watching you. Can we go back to Chandramohan, please?
Yeah. Section, please.
Chandramohan, we are with you.
Yes, sir. Sir, I have opened the posterior surface, and this is the sorry. I will hold with the. Just give me time, sir.
Sure.
This is the fourth arm. I will toggle.
Let's go to the audience for a while. Anand, what is your take on your management of DVCs? What do you do when you dissect and how do you close?
Sections for me.
Everybody started sleeping. It's 8:30 only.
Thank you, Dr.
My right hand instrument.
I think the key in any surgery, I've been telling this for a long time, you need to be seeing what you're cutting, right? If there is a lot of bleeding, it's naturally difficult to see that area. So this surgery that Dr. Mahir showed was fantastic. The way the assistant is dropping some fluid from the top, they're able to see well. But generally, DVCs bleed, right? They bleed like stinks
Do you
sometimes.
increase the pressure at that time?
Yeah, but stitch it first. So that would be my advice. If you're starting out, stitch the DVC first, and then slide underneath. So a lot of talk
It's
about
not closing.
there's margins higher when you cut you stitch the DVC and cut it later.
Section,
But
Swami.
Good surgeons here who are doing
Swami, you're not active.
reduced sparing prostatectomy, and they go and cut the DVC one layer below, and they're saying the margins are the same. So I don't think personally that cutting and stitching or stitching and cutting increases your margin raise, but it definitely makes you see better. So my protocol has always been to stitch, cut later.
Before you came, also we had a discussion on lymph nodes. How do you manage lymph nodes if they're not visible?
Right hand instrument.
So in prostates, I think the fundamental concept is whether lymph nodes are prognosticative or they're curative. So in prostates, it's definitely for prognosis, not as a curative entity.
Let's leave
And
it here when they
even like
Section.
sir was alluding to it earlier,
go,
when you're doing
राइट हैंड इंस्ट्रूमेंट निकाल दो, उल्टा उल्टा घूम रहा है ये.
bladders, it's not useful. It's just standard
हाँ,
lymphadenectomy.
लेफ्ट हैंड इंस्ट्रूमेंट उल्टा उल्टा घूम रहा है
What
ये.
is the case of doing an extended
My
lymph node?
God.
I think things are going to change. Next guidelines.
Keep
that we
sucking,
get,
Swami.
With the advent of PSA method.
I think
Keep
lymph
sucking,
nodes and
Swami.
prostates, don't beat your head about it. Bladders,
Saline.
it's reasonable to do a good lymph node dissection.
Okay.
Thank you, Chairperson.
Yes, Uncle.
Thank you, Chairpersons. I think it's the time to change
Good.
our
Just a
experts.
second. Dr. Meher would like to talk to you first.
Yeah.
Dr. Meher, you're on.
Yeah, so I just wanted to show the specimen. So it's always good to inspect internally. So that's give me the left hand. That's the
मेरे
anterior
इसको
part.
पला होता है.
Bladder neck looks okay.
Don't scrape like that. Don't scrape like that.
Looks fine. Then on the left side where we did the nerve.
Don't scrape like that. Don't scrape like that. Just do water suction.
There is no tissue there. On the right side at the apex where we preserved that little dilated vein, that's this area. So give me a little more margin for the apex, but I don't see anything, there. So it's always good to examine your prostate after you're done.
लेफ्ट हैंड क्यों ऐसा हो गया? लेफ्ट हैंड
Very nice.
निकालो.
What I do is if I have some venous oozers on the bundle,
लेफ्ट हैंड उल्टा घूम रहा है यार.
specific figure of 8 sutures. I don't do any cautery, and then just try to close it. I don't know what the protocol is, what most people are doing, but we give DVT prophylaxis to all these patients, so everybody
लेफ्ट
gets
हैंड उल्टा घूम रहा है यार.
etc. And in fact, something for the first 4 weeks.
चलो suction.
Per guidelines, AHA guidelines. So there is a slightly
Suction.
higher risk.
Keep on doing suction.
If you don't get perfect hemostasis, so I just like to spend a minute or two.
Okay, keep on doing suction.
Close, and then this way your hemostasis and post-op bleed rates are.
No, 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 no.
I must say that pelvic hematoma post-op may not bleed much in terms of blood loss, but its morbidity in terms of.
Can I cut this?
Sometimes distraction injury on the.
So, can I cut this?
Etc. is extremely, can be extremely frustrating. So do your best.
Thank you. Yeah, thank you, Dr. Meher. I think it's a wonderful dissection. I think it's time to change our chairperson. So I would like to invite Dr. Arvind Ganpwet, Dr. Rupesh Shah, Dr. Uttam Mate, Dr. Anil
The
Ahmeds,
pedicle.
Dr. Bastav Ghosh, and Dr. Kim M. on the dais, please. And we can continue with Dr. Malik. Dr. Malik, are you with you? Can you connect to Dr. Malik Uwar?
Hello.
Yes, Dr. Malik, Dr. Ankur here.
Hi, Ankur.
Yes, sir. So just tell us exactly where we are right now.
We are just, I have lifted the median lobe.
Am I correct, Swami?
I know where I open in the posterior aspect.
Suction drop हो रहा है. The gas चले जा रहा है.
So I am just marching in that same area so that I am going to separate the bladder from the median lobe. It's a large median lobe. Had a traction onto the median lobe by having a stitch onto it. You saw that. I identified the ureters there. Both are.
What is this?
This is the ureter here and that's the ureter there. Both are intact. So I'm just
Rectum,
separating
na?
thick-walled obstructed bladder away in the trigone area. You see, the problem here is I err on going towards a little away from it because
Can I do this here?
go into it will end up in a traction on the prostate and creating a plane like a PPH plane. So you may just
Swami.
clear the median lobe without actually taking out the peripheral zone. That's a mistake that
Okay,
can
here.
happen in a robotic. When you are doing robotic, you can think about happening it when you have too much of traction on the median lobe. So this is what, suppose you have too much of muscle here, you may go in a enucleation plant. This is the posterior dissection
This is
what I
the
have made, and I've
pedicle,
gone
na?
to that area. I think I'm clear now.
Yeah.
Somebody retract
Malik
this.
said,
Yes.
Uttam Mete, Anil Ahmeds.
This is the pedicle, na?
Okay. I think there are so many other people. I think you have heard. We are 5 now. So the question was how to tackle the median lobe. So what are the ways you
Okay.
tackle the
Can
median
you
lobe?
clip?
I don't know. When I do it, whatever traction you want to give, put a stitch and then put a traction
Or
and
should I
then
cut?
go in between the median lobe and the bladder wall, isn't it?
Clip.
So put a traction is very helpful while dissecting the median lobe.
See, there is one thing we should understand. It depends upon median lobe how big it is. You have
Wow,
to
clip पूरा पलटले.
you can't see what is there posterior to it. So it is taken. But the only thing is, how do you put traction? There are people who take a, if suppose I do a robotic, I take a third arm and put a traction there. Somebody takes, if it is a small median lobe, they take a,
I think we have finished Swami here.
itself creating a traction onto the median lobe, but it is too
Clip.
big, so I had to take a help of a stitch which held onto the median lobe, and in fact it's posterior and anterior. Usually we don't see this sort of a median lobe. We always see only anterior, only posterior part. This is anterior is more bigger than the lobe.
This is the denominator fascia.
It's a complete intravesical projection of the prostate rather than a true median lobe in this patient. So I had to take a bite and I have to lift it up. Without that, I don't think it will be possible.
That is exactly what I'm telling. So there are different ways to tackle, but what I do, what you had done, that is put a stitch, and that gives a little bit better traction, and then you can dissect it better, isn't it?
Yeah, absolutely. Depends. And if it's a small median lobe, I can
No rectum, na?
even having a thing. It entirely depends upon. If you're not able to see, have a good vision by having a good stitch. That's all. That's the only thing. You see, I had opened a small DVC there. It's a very
Right.
old DVC. I thought I'll pull the bladder, then only
Cut it
pull
up.
the DVC. I didn't do anything to DVC, but this stitch and pulling it
Come
up
on.
will control the DVC bleeding also to a certain extent. So whenever there is a DVC bleeding, don't go on meddling there in the DVC area. Just come back, drop the bladder, or have a catheter which
Caesar, be ready with other one.
prostatic upwards, that will close the DVC. So that's what I did. I haven't done that bleeder in the DVC. I opened a big vein in the DVC, but I haven't done anything to it because of that reason. So whatever I do at that point of time, it will not be able to get control. So I end up in doing more
Okay.
bleeding and more damage. So I just want to mobilize everything ready, keep bladder, the prostate ready. Prostate.
We'll go now.
Think about controlling the DVC. I think it's
Malik sir, in such a big median low, one more tip, what we can do is you straighten up a needle, bring it from the
Okay.
anterior abdominal wall, stitch it
The
through.
fat
So
has come.
your one consistent arm
Okay.
is spared. Well, then
Suction now.
Yeah.
Yes.
I
So
think,
your
I think,
assistant
I
arm
think
gets
everybody is
spared.
talking the same thing, how to retract the
Yeah.
The entire thing is released.
Whether you
Spare
want
the
to
one
use
assistant arm.
the arm of the robot, or you want to use the suture, or you want to put the suture through the abdominal wall.
Yeah.
So anyway, you
Very
have to
small
retract. Otherwise,
prostate.
you cannot just.
My point was,
question,
sir,
Malik
that
sir.
we preserve we can prevent one arm to be, we can spare one arm that can be used for.
So I
Okay.
just want to say,
Malik sir.
most of the time, one small thing, most of the time we end up in giving too many clips from dropping the bladder from here onward.
Chalo, we'll go to anterior.
Big vessel which supplies, or probably two big vessels which supply the prostate. So get into the posterior lateral aspect as low as
Drop it.
possible.
Jai
Then
Bajrangbali.
the pedicle. There is no point
Okay.
making clips right from
Now no
beginning.
nerve sparing, na?
I see most of the time people having clips right from beginning. It's onto the onto the bladder rather than onto the prostate.
Now-
One more trick is just divide this sheath, what is there on the prostate. It will expose the whole pedicle in front of you. See this? The whole pedicle is in front of you here. So
Sir,
that's it. Yeah,
Yeah,
go ahead.
sir, it was a large median lobe. So before cutting the posterior bladder neck, had you seen the ureteric orifice, or had you seen?
I've already shown it. Oh, I already, in fact, I demonstrated it when I started it off.
Yeah, we saw that.
Now I just showed it. I just showed that I identify the ureteric orifice. Otherwise, I'll show you a complication in the evening. What will happen?
Sir, you were mentioning something about entering into the median lobe or something. Can you make it clear one more time?
That's a important point, Ravi. I think people have to understand that. What happens is, if you cut what you do in a routine prostatic enucleation, you cut the bladder wall here and try to enter into a plane between the prostate benign adenoma.
Suction Swami, ఎట్టి పరిస్థితుల్లో కింద బ్లడ్ పూల్ అవ్వకూడదు.
Mistake that can happen if you have too much of a traction onto the median lobe. You enter
స్వామి
into the
సక్షన్ స్వామి ఎట్టి పరిస్థితుల్లో కింద బ్లడ్ పూల్ అవ్వకూడదు.
without your knowledge. So please try to avoid that. That is what I wanted to say. If I look at the lymph, the nerve here,
I will release the endopelvic fascia.
and if you go, this is going to be the neurovascular
Okay.
bundle. You see that vessel which goes all across the neurovascular bundle. This is descending branch. So I would need to go at this level and go onto the surface of the prostate to get a correct interfacial dissection. On the left side, I'm not planning it because the disease is on the left side. I'll be planning it on the right side to get the interfacial dissection, so that at least the guy will be having one side nerves preserved, at least for continence, if not for erection. So this is what happens. This is the prostatic pedicle which I dissected. I thought I opened into the bladder when I was dissecting it. No, it was not open. And this is the prostatic pedicle. And you see something. This is the neurovascular bundle on the left side. But here I'll go on the surface of the prostate and push the neurovascular bundle completely onto the lateral aspect. I think I'm clear.
Okay, thank you. Thank you. Let us go to Dr. Mihir's theater. I think he's doing the anastomosis. Dr. Mihir. Okay. Dr. Mihir, are you with us? No. Dr. Mihir.
Yes, we can hear you.
Okay. So, do you put Robo stitch routinely?
Yes, I do. And not as much for any continence benefit. I don't think there is any proof to demonstrate that. But I just like the way it sets up my anastomosis. So I do put a Rocco stitch. The only time when I avoid it is if it's a, push the catheter out, I need the catheter. Catheter bar karo. Come on, yaar. Push the catheter in.
So when do you not put this Robo stitch, or it is a routine for you?
No, this is I'm going to show you what to do if you nail the catheter with the.
Somebody is touching the camera, please.
Assistant should. I'm going to just take it out. No, no, no.
I think okay. Passed into the
yes.
Okay, scissor is actually hang on. It's not a very small thing, so we should be able to. Don't pull. Give me a scissors in my right hand.
You can cut towards the catheter.
Yeah. This is just a nuisance thing. Hang on. Yeah, but I was saying that I do take a Rocco just to set up my anastomosis. I don't think it changes the continence part a bit. The only time I don't take a Rocco is if there is a posterior wide excision, in which case, needle rubber back, in which case I'm worried about my Rocco going through the rectal wall and creating a fistula. I don't do it. In salvage cases, I don't do it.
And what is the suture you using?
This is they have given me a Stratafix a quill. Stratafix. I personally use a V-lock, catheter rabo. I personally use V-lock, but any braided suture is fine.
Meir sir, while doing urethral stitch, is there any trip and tricks to avoid urethral tear? Or
always. So when you're doing the posterior wall, there is not much sphincter tissue there. So take a nice generous bath. That's the strength of your anastomosis is the posterior wall. Anteriorly, where you have urethra, that's where you want to take a slightly lesser stick. Also, the direction of your pull is important. So for the posterior wall, you pull when you're inside the bladder and you pull towards you. So I'm going to just show this now. So I don't pull right now. I just take the needle out, follow the curve of the needle, take my bladder bite.
Okay,
and
anyway,
pull towards you.
Yes.
And then you pull like this. You pull towards you like this. So that avoids any tear on the urethra. And when you're taking it for the anterior wall, you pull upward. And I'll show you that in a second too.
So is there any trick so that your urethra doesn't get thinned out while dissecting?
Pressure raise karo.
So you don't dissect distal to the urethral incision. So your dissection should not try to electronize the urethra. It should stop at the apex of the prostate, and you just divide down below.
Okay, in this particular case, I think you had done the bladder neck preservation. So that is also my routine for bladder neck preservation. We can do it, but in case of big, median, lobe, you may not be able to preserve the bladder neck. So in that case, you have to reconstruct. So what is your way of reconstructing?
Yeah, so I do a fixed mouth reconstruction if it's wide. I do a stitch at 3 o'clock and 9 o'clock and pinch it. Some people do a racket handle. I think it's
Suction.
I just like the
Last time जैसा suction नहीं आ रहा.
the bladder neck lies for the anastomosis of the fixed mouth.
Suction.
And what sort of suture material do you use for reconstruction? You use the vesicle or you want V-lock? Again, V-lock. 2-0.
I use V-lock for the whole prostate anastomosis.
And this anastomosis you are doing with 3-0 or 2-0?
3-0.
3-0. So it's always because some people they prefer 2-0. I don't know what is the advantage of 2-0.
No, I think it's too big for a braided suture. It is too big a thread, and I just worry that it causes a bigger hole in the urethra. So I think a 3-0 stitch is more than enough for anastomosis.
Even
suction.
Yes.
Both of you use suction.
2-0. 3-0.
3-0. Okay, coming back to that DVC, I know there are several ways to handle that DVCs. Initially, in my career, in the early part, I also used to stitch the DVC first and then cut. But now I have seeing so many people
pressure raised.
cut the DVC first and then suture it. I think that's the best way. Not more than 50 ml blood will be lost. And I don't think there's any need for any increase in intravesical pressure while cutting this DVT.
No, exactly. And the key is the following. See, when you cut the anterior wall of the vein in the DVC, it will bleed a bit.
Suction.
The moment you cut the posterior wall of the vein, it stops because now pneumoperitoneum is able to tamponade at that bleeding.
Okay, Amnath.
Arterial spurters will require point-specific cartridge. So as you're cutting, if you cut it slowly and
Cutting.
you will find the moment you cut an artery, it will be pulsatile. You just do a little quick zap there. For the vein, you just make sure that you keep
Catheter withdraw.
so that you cut both the anterior and
बस थोड़ा
posterior
ही. Amnath, stay
stop
back.
bleed. So I agree with you. It doesn't really cause much bleeding. In very rare instance, you have such high venous pressure
बस.
that it'll cause that bleeding. It generally is very manageable, and I have complete confidence then that I am not getting into prostate apex and I'm able to follow the contour nicely.
Dr. Bir, one more just query because of this is relation to the nurse pairing. So
Gland
I've
is there.
seen Professor Ash theory is doing hydrodissections. Actually, he had demonstrated both in Chicago as well as in San Antonio also. What is your comment about that hydrodissection? Very nicely seen 3D. We can see more or less each and every nerve fiber. So what is your take on that?
So my take on a lot of these techniques is do what you think helps you and which logically is correct, because it is very difficult to quantify the benefit in terms of the quality of nurse training. Because as we all know that the functional outcomes are not even just technique dependent, right? There are patient factors. There are multiple things that go toward making a certain thing patient continent or potent. So in my mind, a lot of these technical trips, it is very difficult to judge if that there is any impact on continence or potency. So I just feel that in most cases with experience, you are able to get, as you saw today, into that plane nicely. And so I've not done it enough to comment on its pluses and minuses, but my overall thought is why mess with it if things are going well. So I'm happy with the way my technique is, and so I wouldn't think that in my practice doing a hydrodissection, etc., or any such similar thing would benefit. But I think if you feel in an individual situation that technique works for you, you're able to better identify the interfaccial plane and get the nerve off, then go for it. But I don't know whether you'll ever be able to quantify its impact on functional outcome.
But because that was really, really very beautiful videos he had demonstrated. Okay, there's a
Can I
question
cut
from the
this?
audience.
Mihir sir, what is your
Amnath.
opinion regarding the modified Rocco stitch to strengthen the posterior urethral plate? And is there any advantage of it or not?
So as I said, I'm not convinced that the data on continence are clear cut. As I said, when you look at any technique-based intervention and its impact on functional outcome, you are never going to be able to definitively say that this helped me with continence or potency, because there are multiple factors you can't control for that. Even if you did a randomized trial, you're never going to be able to control for
Suction.
all the variables. So I just like the fact that
Suction
the
here.
way I do it, and that's why I take the posterior denonvillers first, and then the anterior denonvillers, so that it distributes the tension, it lines up my anastomosis well, and so that's why I like it. So now the anastomosis is done. We'll put a fresh Foley catheter in. Catheter in, please.
Sir, can I ask a question to Malik sir, please?
Yes, sir. One question from audience.
Malik sir, please. So my question is, sir,
Dr. Nair, we'll keep watching you. We'll get back to you on the audio.
Hello?
yeah, Malik sir, this is Gaurav from Kolkata here. Sir,
Yeah,
you
suction,
are
please.
doing the right nerve sparing on the right side exactly the way you do. And
Can I cut
I
it?
wanted to know that how often you are able to demonstrate the landmark artery, that famous landmark artery, and tell me the steps that what you are looking for, what you are doing exactly for the nerve side.
I was asking for a connection for that reason only. Look at.
Yes, sir, I was watching you.
This is the arcus tendus fascia pelvis. I made one layer which went along with the levator and a muscle, and I am opening some more layer. You see, this is the veins which will come out into the pedicle here. So I come into an area what I term as a bare area or on the side of the prostate, and I divide that fascia and come under the fascia to shift the neurovascular bundle away from the prostatic surface. Presence of a landmark artery is sometimes seen, sometimes not necessarily seen. Sometimes even if it is seen, it is quite lateral. Sometimes it is very well appreciated. In this case, I saw the landmark artery on that side. But this side I have to see whether I can see. You can see the artery descending from this prostatic pedicle, going down on that side, going down on that side. That's a landmark artery. And this is the nerve, this is the fascia along with the, yeah, I can see one I don't know whether it is sick. I am not able to appreciate it here.
Put this and both
Possibly I try to dissect and this prostate is too big. So I have hardly any space.
Yeah, I can understand. So, sir, what I'm asking you about the technique that if you are doing robotic, you find it more that okay, you are able to demonstrate it more than compared to laparoscopy because
Of course, robotic makes it much more easier. But one thing what I want to tell is, this is a prostatic pedicle which goes into the prostate. This is the veins which come from the DVC and drain into the pelvis, and the neurovascular bundle stays here, which gets stented here and goes underneath the prostate here. So when it gets
Somebody
stented,
hold
don't go
this.
at this juncture. Go here.
Yeah, suction
Stay near
saline.
the prostate. Don't get this angle
Saline.
across. That's the only thing what I can
Saline
say.
full.
Whether
Come
it's
on,
safe,
yaar. Saline,
it
yaar.
does not click to me. Is a different point. I really don't look for it. If it is seen very well, that's very good. But I think I should be
Two
able to
sections
appreciate
పెట్టుకున్నాను.
that better.
Saline, keep saline.
Robotically, no?
robotic technique. Okay, thank you, sir.
Hello. Yeah. So just wanted to kind of any final questions. We're done with our anastomosis. So we back the specimen.
Yeah. So one quick
final questions.
one question, sir. The rectal injury, regarding rectal injury during robotic surgery, how whether you encounter it is very safe during robotic surgery, and which kind of prostate or which kind of disease you find such injury?
So rectal injury obviously can happen during any approach. I personally feel robotic surgery gives you the best view of that posterior plane. So even if you're doing a difficult situation like if there is posterior extracapsular disease or there is radiation or there is a very adherent prostate from prostatitis or whatever the thing may be, the ability to see the plane better with robotics is unparalleled. And also because of the, as you know, as the rectum goes distally towards the apex, it rises up. So that's the direction. So you have your wrist of your instrument that can follow the rectum nicely. So that's number one. The highest chance of rectal injury occurs in wide excision. So when you're doing a wide resection,
Chalo.
not a nerve sparing, you're going wide, and most of the times what happens is
Okay.
do not release
Keep
the
sucking.
rectum posteriorly, and it
Raise the
takes
pleasure.
up, and
Saline
that's
and
where
suck.
you can get a
Give me the needle holder and
if you have recognized the injury and if it's a small injury,
Vilak.
there's really no sequela. You can
Vilak
close the
బాగుందా?
rectum in 2 years, and as long as it's
ఇది
free from
fourth ఆమా థర్డ్ ఆమా?
infection and spillage, that should heal well. If there is
నేను థర్డ్ ఆమ్ తీసుకోవాలి. I'm not.
or if it's a large injury or
Don't rugget.
you know,
Don't rugget. Just put
radiation
saline and suck.
so that's when you may need to do a
The
diversion.
Vilak, please. Normal Vilak 20.
If you do get a rectal injury,
Put the Foley's catheter.
that your urethral anastomosis
One person
is
put
perfect.
suction. One person saline.
In there will absolutely cause the rectourethral
20 better కదా?
anastomotic fistula. So
30 better స్వామి.
very important to make sure that your
Ah.
anastomosis is absolutely watertight. Take your time. Make sure you put everything.
Give me ready. Put it. Take out the right
So
side.
that would be my thing. But the risk
Left.
would be very, very, very
I feel
That
which
being
one is
said,
better? The same
do
thing is
you
better.
routinely give enema before that night before surgery? No, you don't. It doesn't help.
Which one is better? This is or below one?
Some situations we give an enema. But you know, I always do
This below one.
exam when the patient is under anesthesia so that you get a good feel of the prostate. That's the best
Ah.
way to do rectal exam.
Anand को mic दे दो.
Much more information than when you're doing it in the office. And
ఇంకా అవసరం లేదు రాజా మనం.
there is
Suction.
significant loading there, you may want to just give empty out the rectum at that point. But I routinely do not give any bowel separation.
One last question, sir. Excuse me. So one question from me,
Right
sir.
hand instrument.
Sir, any tips and tricks for a narrow pelvis?
Foley's catheter in.
Male patient, narrow pelvis,
Yeah.
and you are
Right
doing
hand
anastomosis, there is
instrument.
very less space. So apart from reducing the pressure, anti-burping, any other
Saline
tips and
suck.
tricks
Please
you would
don't
like to
stop
give,
that.
sir?
Saline suck. Don't stop, Swami.
Anti-burping is, I think, the best.
Don't stop that.
It
Saline suck,
allows you to
please.
go underneath
Keep
the
doing
pelvic
it.
bone, but you just have to minimize your movement, and it'll still rub
Come on,
against the
fast.
wall. It'll still cause some oozing from the pelvic bone. You just
Saline
have to,
suck, please.
you know, muscle through it. There's really no
Right
other
hand
way
needle holder.
of handling it. But I think the anti-burping is probably the most useful tip in that situation.
Okay. Sir, last question probably. regarding the
Right hand
anastomosis,
needle
some
holder.
people take the DVC during the anterior part of the suture.
Right hand needle
Do you
holder
think
not
that makes
moving.
any difference in
I
stabilizing?
mean, you could, but I just what
Suction
I like
saline,
to do is
please. Swami,
your
don't stop
anterior
suction
knees will
saline.
bite a little
Swami,
bigger. I like to keep my
continuously
anterior
do
knees bite
saline
very
suction,
small
please.
because
Hit
that's where
saline and
most of the
suction.
sphincter tissue is. The horseshoe sphincter at the
You are
center
not able to
is
put a
mainly anterior and lateral urethra, not as much posterior. So I like to keep that bite very small. So I just feel that
right hand is not moving. People will watch now
just
this only.
anatomically more convincing to me.
Here, last question. There are few
Okay.
surgeons who complete the anastomosis and then put
Needle
in the
holder is not
catheter.
holding. My
Then
God.
yes.
Suction
And there are
saline,
few
please
who
keep
do
doing.
one
That will cause the
wall and then put
coagulation.
in the catheter. So use
I think if you do a good
Suction saline,
anastomosis
please.
robotically, the catheter should walk in easily.
Don't
The reason
trigger,
that
don't
because
trigger.
of
It
the
will cause
setting
more bleeding.
that occasionally if the catheter
Saline
were
only,
to come
saline
out
only, and put
for some reason or the other,
needle holder
the
right
ball
hand.
didn't walk in smoothly. I know that anybody post-operatively
Saline on.
shows up in some emergency room somewhere, they'll be able
Don't
to put
waste
the
time.
catheter in well. So it's a trial test for me.
Bas.
I almost never have had a chance where I've had to open up the anastomosis to put the catheter in. Because as you saw, the robotic
Ready?
the anastomosis aligns up
I'm going, Hemnath.
so the catheter should just walk in.
Yeah, I don't know how many of us in India are doing salvage prostatectomy. What is your experience of salvage prostatectomy
Okay.
and how difficult it is, and what is your
How
functional
deep?
outcome for those cases? I
Huh?
don't know, in the audience, how many of us are doing salvage prostatectomy? Anybody? Nobody wants to start that process.
Okay.
Okay, so what is your take?
Yeah, so we published our experience on about
इसको depress करो थोड़ा.
prostates. So
Suction, please.
technically it is not as challenging.
Continue suction, Swami, please.
Anatomical landmarks, I think you can get the job one. In fact, it bleeds very little. Radiation destroys blood vessels and vascularity, so it doesn't bleed much, which actually is a problem, which is why healing is unpredictable.
Where is the
So
opening? This is the opening.
problems with salvage are the following: your anastomotic leak rate, even
Okay.
watertight anastomosis,
This is opening.
if you were to do a cystogram, about 10 to 12% of these patients will have some leak still, and their average duration of catheter in our experience is about 12 days, which is double of what we keep for our standard cases. So that's number one. Number two, obviously there is no real scope of nerve sparing, so the erectile function is very poor. Incontinence rates in our series was about 12%, so which is much higher
20
than
length is more,
primary
na?
setting. But the more important part is that these patients have a higher chance of developing a anastomotic stricture because the vascularity of that is low. So what I would actually do is if you're dissecting it and if you find that the urethra is very unhealthy looking, it is actually better to excise that urethra and attach it in a normal looking urethra. In fact, in some occasions, what we also keep ready, and we kind of do a cystoscopy beforehand to see what the urethra looks like. But what we would do is actually have a urethral surgeon mobilize the bulbar urethra from below and do what is called a pull through. So they actually
Suction, please.
get
Keep
more
doing
length and
suction.
get the
Don't
urethra
stop
that is outside
suction.
the radiation field.
Swami, repeatedly
If you
I'm
do a
telling.
pull through,
Please
these
catch my
patients are
point.
guaranteed incontinence.
Not
But
now
I
water.
much
Not
rather
now
deal with
water.
not
Not
even
now
patients
water.
that can then get a sphincter than a
This
continent
is the
patient who then
bladder
develops a
opening.
contracture. That
Sure.
is, the incontinence is much more easier to manage than a bladder neck contracture. So we've now done about 14 patients
Okay.
who've had a pull through at the same time where you do a perineal dissection of
Just ask Anand, ask Rajendra to come.
the pelvic floor to deliver the urethra up there through the pelvic floor. You get a way more length and you get
Okay.
urethra that is outside the radius.
Little less. Hemnath.
I think
Okay.
there's a question
One
from the
last
audience.
question. What is your experience during check laparoscopy? You have to take down the anastomosis for bleeding, and what are the tips and tricks to avoid such? I mean, apart from meticulous hemostasis.
Don't drag now with.
Hemostasis is an important thing.
Don't drag.
I'm
Only
a firm believer that if
suction when I am not doing anything.
in the first 24 hours, if you do a scan and they have a large pelvic hematoma, you should, even if they are hemodynamically stable, if
Suction.
transfusion
Ask
required
Anand
is
whether
not,
the screen is on.
that
Suction.
is one instance
Just
where
only
it is
suction.
worth going in to evacuate the hematoma. It actually will improve the post-operative course significantly because the pelvic hematoma causes pain, it causes ileus.
Go back.
Also, it can
Don't
cause
put
a
water. Don't put water.
and the problem
Suction.
with distraction,
Swami, don't put water.
these take a longer time to heal because unless the hematoma resolves,
Bladder urine.
and the
Bladder urine. Suck.
that leak will persist. And these patients have cystogram after cystogram that show persistent.
Oh, police. The police pass.
The hematoma is in the first 24 hours. Once it gets
Police
organized,
pass.
it becomes much more difficult to do.
Yeah.
So I would
Wait.
strongly recommend you
Go back.
evacuate
Suction.
that happens in the first 24 hours.
Thank you, Dr. Mihir, for this nice dissections and nice demonstration.
Suction.
Let us give a big clap for Mihir. You can hear it, the big clap. A good round of applause for Dr. Mihir. Thank you, Dr. Mihir. And I think
Little less.
Dr. Mallikarjun, who's waiting to talk to us.
To the OR3.
We're going to Dr. Mallikarjun. Yes, sir, you're on.
Okay, I think I have preserved the nerve on the right side, fairly
Okay.
okay, and I'm giving some sort of an intrafacial
Okay.
dissection on the right side. I was a
No
little
suction when I am doing this.
compared to right side on the left side. This is it's a large gland. That's a pain. That's the reason why I'm not able to show that.
Yeah,
clear
suction now.
anatomy. But I think if you look at it, the surface of the prostate is absolutely, take it sidewards. Surface of the
Suction.
prostate is
Get the
completely
Foley's.
thin, and this is a neurovascular bundle which is
Foley's
separated
come.
and fallen across.
Go into this
So
and
I'm staying close to it, and then I couldn't demonstrate any
wait.
psychiatry specifically in this case because
Yeah,
sometimes it is
pass it into it.
we may not be able to notice.
Drain it.
So Malik, with such a large gland, how do you, what the tricks to give it counter traction as you dissect off the surface of the prostate?
Oh no, I didn't understand.
It's a very large gland, so you need
Suction.
to do some retraction on the.
I'll cut it off here.
Yeah, it's there.
Huh?
So how do you, what
No need, na?
It was there, which is
Yeah,
which
cut
was
it off, scissor.
retracting it. Now Rajesh is holding it with a tooth grasper, the edge of the bladder, and then retracting it.
Yeah,
We'll
give
keep
me
wa-
Bila,
Sir, we'll
the
keep
suction,
watching
please.
you. Can we go
Scissor,
to
quick.
the
Cut it off, cut it off.
Sir, theater?
Either Bruce, you suck, Swami.
Dr. Chandramohan.
Bruce. Yes, sir.
Dr. Chandramohan.
Yes, sir.
Nilesh, could you unmute Dr. Chandramohan, please?
Cut this. So I have taken the roca stitch. Take out the police.
Could you
Take out the police little bit.
Dr. Chandramohan, please?
Hello. Yeah. Hello.
Dr. Chandramohan.
Yes, sir.
No.
I have removed the specimen and now I have cut the.
Chandramohan, before you talk, let us talk a little bit. So, how are you?
Fine, fine, sir.
So, you can see that you are just doing the anastomosis.
Yes, sir. Take out this
in
leaf.
the same hall, we are seeing two different robots and
Take out this.
surgery. The perception of all the people who are watching here, that the color what you are showing is really not good. It's not soothing to the eyes. So
Yeah.
we have seen also that I will see also. So what is your take?
Sir, this is the.
It is like that.
Yes, sir. This is the Olympus HD single chip. The transmission color slightly inferior. It is not good. They are planning to take to the storage also. So, saline, sir, please here. Slightly the transmission will be inferior only, sir. No doubt about it. This is 5 crores. That is 20 crores. So I tried my level best engineering.
But the question from Dr. Bhaskar is, see, the same transmission is being done for Da Vinci also. So why?
No, sir. The camera. Go back. Can you put the?
Chandramohan said it's a single chip camera.
Yeah, single chip camera it is.
It's a single chip camera. Very, very important point to note.
So this is single chip camera. So quality will be little inferior. At least are you seeing the Foley's catheter or not? Sir, are you seeing the Foley's catheter directly or not?
Chandramohan, the whole idea is, see, we are a developing country, poor country, so we would
Yes,
like to
sir.
have a machine with a lesser cost, cheaper rate, but with a similar sort of outcome. But if we are seeing the same thing here, it is really not soothing. I don't know whether it is really impressive
No.
to all the audience. Sir, what is your take, sir? Dr. Ajay Kumar, sir.
Uttal, don't be negative.
Go.
Something which has been developed in our own country. And last one we saw Harish, doing, what's his name? Sudhir doing the difficulties he had that time. And now we are seeing Chandramohan having much less difficulty than what he was facing. That means there is a development. And here, it's not the fault of the machine. Mantra, it is the fault, not fault actually. It is the deficiency of the Olympus camera, which is only single chip. It is with single chip cameras, light adjustment may be little difficult if I am not right. Okay. Thank you very much. So let's not be negative to the new technique developed in India, and we should encourage it. Thank you.
I request Dr. Gopal Sharma, Dr. Anil, and Dr. Sumit Mandal to upload their presentation for the next session.
Chandramohan, how is the suturing? Tell us about that. Is more important. If we compare, it looks pretty good. You are able to do the good suturing. So, how about this mantra robot suturing? Can you tell us?
Yes, sir. I'm suturing now. So far, I don't have problem. My vision is also not that bad here. Police catheter. Police catheter. Yeah. Go out.
So Chandramohan, what suture are you using?
Sir, I am using 20 euro 1 needle. See, sir, wherever I want to get the bite, it is coming.
Yeah, Chandramohan.
Without any second attempt, it is coming.
Yeah, I have used both the Da Vinci as well as off late SSRI. I found it extremely difficult for a person who has done Da Vinci to switch back to SSRI. Extremely difficult, especially.
See, sir, anastomosis is the first. Are you able to see, sir?
Yeah.
Are you able to see the first police catheter pass? See, good bite has come.
Chandramohan is fine. Somebody, okay, so from the audience, some comment is being passed.
Are you able to see the police catheter and urethra approximation, sir?
Yeah,
Chandramohan, just hold on for a minute, please.
Yeah, and for a person who has switched from laparoscopy into Robo, this SSRI is extremely probably they augment their skills. But for a person who is experienced in Da Vinci to switch back to SSRI, I find it extremely difficult, especially with the third arm. Even though it's a modular arm, the cluttering of the instrument inside, it's once it goes out of the field, the third arm, somebody has to take it back and the attendant has to bring it into the field. It's extremely difficult, especially for the kidney surgery.
Section, Swami, I am
Pelvic surgery
repeatedly
is okay,
telling you, you are
third arm
not
is
listening.
good. Third arm is to some extent. And suturing, I found it slightly better than the Da Vinci. With SSRI, it's extremely good.
Suturing is good, sir.
Improve is the instrument and this thing, third arm. Otherwise, it's good.
So person who has already used Da Vinci would not like to go back to
SSRI. Probably it will be good once you do maybe 50 cases, 60 cases, and
Basically, you require
Police catheter.
skills to use a mantra.
So whoever has used to drive
Police catheter pass.
do not go back to. Maybe I'll not pass this comment.
Huh? It's good now.
Maruti, isn't it?
Okay.
Can I ask a question to Malik sir?
Chandra is going to say.
Malik sir, please.
Yes, some comments from the audience.
Malik sir, you are doing DVC suturing right now. Initially, when have you changed it that after cutting DVC you are suturing it later? After your robotic experience, this is the change that you have adopted, or from the beginning that?
No. What happens is, you see, the DVC is very narrow, small. I don't mind suturing it beforehand.
Can I exchange with this instrument with the?
I will not be able to do that because you understand it will end up in having a much amount of tissue crumpled, but it will not be effective also. That's the reason why whenever you have a large wide DVC, I would rather cut it off, hold the urethra, leave the urethra half intact still, and then ligate and then suture the DVC. By cutting the urethra completely, you lose the advantage because what will happen is it will start.
It will retract.
It will retract, and you will not be able to see properly. So that's the reason why whenever there is a large wide
Come out.
like this case where the
Go in.
is so huge and wide, we'll definitely think about suturing it at the end. That's what I've done, and I think it's enough. I don't think anything else is necessary here.
Thank you, sir.
I'll keep this suture and I'll do an anterior reconstruction at a later point. Where is it?
Sir,
Yeah.
Seeing the large median lobe, large prostate, obstructed bladder, and bleeding here and there. So I thought I will just ask you how to, is it at all feasible to preserve the neurovascular bundle in this case? But I'm really surprised. I'm really surprised.
I've already done it.
I see.
Yep.
Yeah.
I have a question on health economics. In our country, if you can do the same, deliver the same thing with laparoscopy, it will be cheaper for the patients, no doubt about it. But if you have the robot, so what are the cases you'll say no to laparoscopy and I'll go for robotics? Because you have experience in both.
Me?
Yeah.
But I would say in my center I do only robotic.
So
I don't do laparoscopy in my center since the day I've got robot. At least for prostate, I'll not do laparoscopy because I feel it is easy, easy to do it. That's all. Not because laparoscopy is it should not be done or something. Before the laparoscopics came, I was doing only before robot came, I was doing only laparoscopy.
No, what I want to say is like this sort of big medium lobe, big prostate, would you prefer to do robotically over laparoscopy?
I don't know whether I really make any much difference just because it is robotic. You see, I tell you, the technical difficulties, what will happen because of the median lobe is going to be there even when you do robotic. Do you think that we are able to see we are going to get more space? Yes.
Pass.
The way we are going to do is going to be easier
Pass,
when you do
police.
robotically. No
Yes.
doubt. You don't need to strain. You have got not much of a real
Bus.
strain what you're going to have and so much of traction, etc. Maybe a little less. But the difficulty is going to be there whether you do robotically or laparoscopically. No doubt about it.
Any questions from the audience? Yes, Dr. Shailesh.
I think, okay, you're doing it very well, Malik.
Finished.
My only thing is for people who have not been extremely well trained in laparoscopy, like myself. I started with robotics and I continue with robotics. But there is no doubt from what I've been seeing, what I've been hearing, is that my colleagues who are trained in laparoscopy can do it both. But when there's reconstruction to be done, and deep pelvic reconstruction, when you don't have a great pelvis to move around with, there I think robotics takes the cake. When you have a short urethra, robotics takes the cake. If you have a long urethra when doing dissection, then you can do it. But on all these short urethras, I thank my God that I have a robot to handle it. Thirdly, if you're looking, this is my experience for the last 5 years now. We've done about more than 700. If I'm looking for nerve sparing, and if not both sides, at least one side nerve sparing in a stuck prostate, I would like to go robotically. That's what my feeling is.
And that's what I'm telling. So, like seen in PJ, it is about over 10 years we are having the robots. So definitely laparoscopy gives whether it helps the patient. The robot. I think the robot helps more the surgeon rather than the patient because laparoscopy and robotic both are minimally invasive surgeries. Outcome supposed to be same if you're good. But in case the patient is poor or after robotic surgery, you have to go for laparoscopy. That's what I'm telling. So even
Pass.
you can see here.
Pass.
I don't know. I don't know how many of us in the audience are doing
Sir, Anand ki woman sorry.
surgery when it is indicated. Because majority of us will get 1, 2, 3,
Suction
4, 5.
Yeah.
Hardly anybody is
Where
doing
I am now?
surgeries. Maybe we are getting the cases in the early advanced stages. That may be one of the reasons where
Anand
it is not
Kirmanu.
indicated.
You can rephrase the question. How many of from the audience are doing now sparing through laparoscopy, not by robot?
So the question is from Dr. Vastav, how many are doing nerve sparing through laparoscopy? I think whoever is doing robotic prostatectomy, mainly either robotic or open. Laparoscopic prostatectomy, very few people are doing it. Am I right or wrong? The audience, if you have a robot, it's fine. If you don't have the robot, maybe you'll go for open radical prostatectomy than this thing. That's what I'm telling. Few people will do it.
Trained in that, they do it.
Again, I think in the surgical, just to summarize the thing, for a robotic or any prostatectomy, there are a few areas. Approach, whether you are going for anterior approach or posterior approach. Most of us in the beginning also, we have started with posterior approach only. And at least I am continuing with the posterior approach. I don't know what is the advantage of having this thing anterior approach. And second thing is DVC, we had already talked about it. So,
sir, can I talk for a minute, sir?
Laparoscopy, prostatectomy, sticking the DVC first and then cutting it.
Can I take a minute?
Okay.
Sir, can I take a minute? Anand?
Yeah, you are on.
Anand?
Chandramohan, you are on.
Yes, sir. See, the posterior layer is over, anterior I turned. See, now I am pulling this. See, entire last 2 bites I take. I think that has cut through. Then I will take this anterior bite, then bladder bite, then anterior bite, suture with this. DVC I have cut, it is not bleeding. At the end, instead of suturing these two, I can go 1, 2, 3, 4 here, 2 on this side, 2 on this side, and leave it. Or else I can take both these knot. So, are you comfortable with the suturing, sir?
Yeah, Singh. Chandramohan, have you heard of a wood technique popularized by Professor Asutosh Tiwari?
Yes, sir.
So what is your comment on that?
Sir, actually, I am in the initial phase of this surgery. It is in the advanced phase, where a new technique is instead of going from regius pairing, he will do like regius pairing. You will make the incision over the prostatic capsule, all around surround, go like that without seeing the puboprostatic, without seeing the dorsal vein. Cut it off everything, go to the prostate, later on put it back onto the urethra. That is what he is doing. That is highly confined disease, it's okay. Instead of struggling with regius pairing, Vipul Patel sir, I think is doing that. I am too early comment on that. I have seen multiple videos. I tried in the first video, but today I could not do it. There are multiple factors that I have not, when I was dealing with the bladder neck, I thought that I will not be able to do nerve sparing, so I immediately switched over to the complete cutting of the neurovascular bundle, and then I came directly last to the dorsal vein. I was clear that I am going to cut the dorsal vein without suturing. There is a narrow length of the prostate is small, so I have cut it directly. Now it is not bleeding.
The whole idea of asking this question is if somebody has not seen his videos, the fantastic video by Professor Asutosh Tiwari.
Yes, sir.
I had seen in consecutive 2 AUM meetings, both in Chicago as well as San Antonio. It's really, I think everybody was spellbound to see all those videos. Really good videos. You can learn the anatomy better. You can learn the dissection better. Whatever technique you do, you have to have good knowledge about the anatomy, and that is nicely seen with these videos.
Yes,
That
sir.
is the message you want to give.
Yes, sir. Yes, sir.
Sir, tell
Yes.
us about that SSRI mantra.
Sir.
Is there any latency between your master clutch and your instrument movement? What do you feel about that?
But as I am not feeling anything from day one, I am not feeling. Only thing is problem is camera. A lot of problem with the camera. They are planning to switch over to the Starge Rubina. They are talking most probably for us also. They will give free of cost that exchanging with this. That happens. I am very happy. Out.
And during posterior dissection, 30-degree up and everything is possible with this mantra?
A problem is if you do in renal surgery, it is possible. Here it is not required. Renal surgery we are doing. See, when I am rotating, I am not having any lag here. See, I am pulling. There is no lag here. Are you able to see the pulling?
Any questions for the audience, please? Don't be silent.
Yeah, move the Foley's in and out. Move the Foley's in and out. Move the Foley's in and out. Out.
Anyway, Dr.
Again
Chandramohan,
pass.
if
Again
you are
pass.
planning to do lymph node dissection, at what point of time do you go for
It is getting cut through. Okay, sir. I will concentrate on here and I'll come back to you.
I am a urologist embarking on my robotic journey. And the take-home message, rightfully or wrongfully, is unfortunately this has been rather a negative publicity for SSI mantra, because I don't think I will want to do an operation with such poor vision that I see here. Now, unless it's a fault of the transmission or perhaps this particular machine, but if you are telling me that SSI mantra gives this quality of images, then I'd rather do an open operation because you would see better.
No, sir.
Please tell me if I'm misjudging.
No, sir.
I go and find 6 more crores or 8 more, 10 more crores to go and make sure that I buy the right machine, because like everything in urology, 80% is of course, or 40% perhaps, not even 80 is your own hands, but with technology, we cannot have substandard technology and then expect good results at all.
I must compliment you for speaking out your heart. That may be the feelings of people who are used to do intuitive, Da Vinci. Now, who are starting with this, I don't know what is their experience. But Ajay Kumar sir, he was
Sir, the transmission.
negative
Sir, there is,
that it is good, it is in the evolving phase. I think there's a comment from.
Yeah, I would like to answer for that. Yeah. Because when Da Vinci came, S was there, SI, XI, X, and G5 has come. Where this Indian Robo, this is a vision is extremely good. It's not a bad option. Give them some time. They'll improve. And the thing is that with the Da Vinci, what is the recurring cost of it more than the initial investment? It is very high. This is very cheap.
Yeah, I know
cannot
everyone is
blind-
a phase of
We
evolution.
cannot blindly say that this SSRI is very bad. It has lots of positive points but lots of scope for improvement.
And definitely,
Police get out.
The camera system, they are changing into rupees.
when you are talking about the recurring cost, the CMC for Da Vinci is around 1 crore per
Yeah,
year.
this is
1 crore
45,000 lakhs after 3 years.
and these accessories, it will cost you around 3 crores. So
Don't come,
per
police, don't
year,
come.
it will
Who
charge
is
you
coming,
around
police, don't come.
SSRI is going to improve. That's what my initial, I would have done very few cases with
Now
SSRI.
you put the police and balloon deflate,
I don't know
balloon
the
inflate,
CMC and accessory cost for
comes around 30 lakhs after 3 years.
balloon inflate.
Initial 3 years, it's free.
Okay.
What is the recurring cost that Da Vinci has increased the number of users from 10 to 15 with a 20% probably increase benefit, 27% benefit for the customer.
So what is the cost for mantra per year, maintenance cost?
No, it's very less.
CMC
Maybe
advertising?
CMC after 3 years, 45 lakhs initial, fourth year onwards.
Sir, I don't mean to disrespect SS Mandra. I wish them all the best. But while they are evolving,
Why shall I buy for this?
I
That's a
cannot risk my carefully built reputation to save money. And therefore, my question, and I'm here to learn today, and that's why I'm asking everybody, especially people who have used everything. When we are embarking on this journey, should we really be starting with something which is still evolving while we are also evolving? Perhaps people who are already expert in robotic surgery can flip around between various instruments.
Everyone is under, I think these are individual perception. Everyone are under evolution. Let's give some time and let's come to our.
Can I just make some comment, please? Yeah. So Dr. Santoshi from Mumbai. Basically, I've been using SI and XI right from the beginning. Recently, I had the opportunity to visit their the main head station in Gurgaon, and trust me, they are not far from reaching SI. The vision what we are seeing here is really inferior because of the transmission. The actual vision what you see when you sit on the robot is far
Yes,
superior.
sir. Yes, sir. I strongly. Otherwise, I might have not.
Yeah, Chandra, I totally agree with you.
Yes, sir. I am enjoying my view here.
So I don't think we need to.
Transmission is equal, not for both.
No, sir. The output.
Sorry, technically, can I interrupt? This is Anand here. Sir, the output that we are getting is entirely different compared to a laparoscope. So what Dr. Chandramohan is seeing is a full 3D vision.
Yeah, exactly.
With a wonderful monitor. So the surgeon has a wonderful view.
And this is the only machine now India has which has the capability of doing 5G telecast, the teletransmission. The Da Vinci doesn't have the technology as it. So to be honest with you and to be fair with the Indian system, they are just short of reaching to the SI technology. XI is far. Probably Da Vinci 5 will be another 5 years. But they're doing real good research. So I don't think we should discourage. And more systems will come in, they will get more funding and they are going to
And full with the police catheter
I
balloon.
haven't used it myself, but I have done the animal model surgery in their
Cut this.
in their head center, and it was really good.
Thank you. I think let's go to the surgery itself now. Can I go to Dr. Mallikarjun's theatre, please?
Yes, sir. Dr. Chandramohan, sir,
we are back,
Malik
sir.
sir. Yeah, Uttam.
So what? So far, we see we are discussing about the mantra versus Da Vinci, and there will be end of this discussion. So whoever has the money will go for this Da Vinci, or who doesn't have the money will go for this thing. I don't know. This is a very loose comment, but in India, I think we should not discourage as per the advice of Professor Ajay Kumar sir. So we are not discouraging it. It is up to the person who is buying. It will depend.
See, one thing, Uttam. Everything initially will have its own problems, but the only thing is sustaining it and developing.
Why bladder is distended?
For it to be in the market.
Bulb deflate a little bit.
And sustain then it will be difficult. If they can sustain, it will stay as any other competitor into the market. It's common with everything. I think there are another 3 or 4 machines coming up. One Chinese is coming up. Hintori is there. So it's bound to be there. This is going to come, and there's going to be some amount of competition between every one of them. And I don't consider that everybody will be on the same regard. Somebody will be having some advantages of somebody will be having some advantages by cost or by another perception. So we need to understand which are the advantages you want to materialize. That's all I look at it.
Malli sir, in Robo, usually the bladder neck, we do the fish mouth or the tennis racket closure. In laparoscopy, do you do it? And if you do it, is it difficult to do the completion of the anastomosis?
No, I don't want to do that in a laparoscopy because it is going to spoil my vision. So I'll do an anterior racket or whenever I do a laparoscopy. In a robotic, I can think about doing a fish mouth closure and then coming back into it. So whenever I do laparoscopy, I'll think about this only because it becomes easy for me and everything is visible in front of you. So you are able to see it completely. And anterior racket is going to be closed very easily when you do laparoscopy.
Malli sir,
Yeah.
you often use this 5/8 circle monocreel, but I'm seeing here you're using a V-lock or Stratafix something.
I think I found this pelvis quite wide and I don't think it's so narrow and the large prostate, I have a space here. So I thought I can think about it. And so as thought, it is working well. Okay. Most of the time in a narrow pelvis, it's having those
Take out and put it.
Tying it up and pulling it up.
Take out, give me the Maryland.
Whereas in a large pelvis like this, where
Maryland.
it is also very big, I don't think it is it's not a problem now. I think I am able to close it without any problem. What I always insist is creating this posterior base, which is very, very good. So I should be able to move the catheter in and out at any point of time. I always take out the catheter at the end of my anastomosis and the sister should be able to pass it without any difficulty. Keeping the catheter and making a knot is more dangerous than having a good check at the end because you should be able to be ready for changing the catheter at any point of time. That is that's my take on any anastomosis. And whenever you do anastomosis, come here, come nearer. This is the area of the external US apron below the DVC. Don't take this tissue along with the DVC. Don't take this tissue along with the anastomosis. That is very important for
take it out and put it.
So one of the reasons why I don't really prefer, though Anant was talking about controlling,
take it out and put it.
Is one of the reasons why I don't want to do a primary
అక్కడ విజన్స్ సరి లేకపోతే మనం ఏం చేస్తాం
ligation of the DVC before I divide is because of that reason, because I want that to be intact, and then if you have you take a DVC beforehand, most likely you will take that muscle also into the pipe, and that is going to be taken away. That's the basic reason why I don't want to do that. I want to cut the DVC and then suture the DVC in most of my cases whenever it is feasible. So I don't take that muscle. I take only the urethral wall, the 2 layers of the urethral wall, and then suture it and leave that muscle and the DVC part away. So the DVC will be used
Scissor cut.
for anterior racket closure. After the anterior racket closure, what I'll do is I'll suture that DVC and this tendinous rate, Marcus tendinous.
Take out the needle.
Support to this patient. That's how I'm going to do it.
Actually, in my initial pages, people used to give the perineal compression. Nowadays, I don't give any perineal compression.
It is not necessary.
Necessary, no?
I would always say, I'll keep the patient supine. If you have seen the patient, it is absolutely supine. Because if you have a little,
so I will take the
because of the pneumo, which is high pneumo, which you create, the perineum shifts posteriorly. So you require some sort of
where is the
pulled forwards, which is not necessary actually speaking. Most of the time, you don't need perineum compression at all. It is very well seen.
And that's what is my view also. Nowadays, I don't give any perineal compression. So there's a message from the organizers.
Take out this instrument.
The next session, there are some talks.
Yeah, we'll keep watching you, sir. Okay. And very nice demonstration in a large median lobe.
Clap for both.
Thank you.
Mantra as well as Da Vinci of India.
Wonderful.
Okay, thank you.
Thank you so much, chairpersons. And we are moving now to our session 2.
Conclusion remarks.
It is a wonderful presentation, Dr. Chandra, wonderful presentation. We are still seeing Dr. Malik on the screen till he's there.
but we'll
I
continue
should
the
thank,
session.
I should thank my colleagues who have come over here, my Gauss and Rajesh. Had it not been there, I would have been struggling by this time taking out the median lobe.
Chalo.
My both right hand and left hand are there here, so it was easy for me to perform. Thanks, Gauss.
Thank you so much.
Team of civil hospital who been bearing me all the time whenever I come.
Thank you, sir. Okay, so now we are with our session 2, that is dilemmas in management of prostate cancer. And I would like to request my experts for this session, Dr. Santoshi, Dr. Anand Krishnan, Dr. Sabnish,
Okay.
Dr. Anish Srivastava,
We'll take some
Dr.
break.
Kishore T and Dr. Keshav
देखो
Murthy to
कितना
please
नेगेटिव कमेंट्स आ
come
रहा
on the dais. And with this, I would like to
है
invite
हाँ लोग अपोजिट बैठे हुए हैं.
the first team, I should say, because now this session will have one talk. The one talk, there are 2 persons who will be coordinating with each other. With this talk.
ओलंपस का कितना बैड नेम आ
The
गया.
first team is from Max, Sake, Delhi,
Huh?
Dr. Tushar and Dr. Harshit. I would like to invite them on the stage for their talk.
हमने सर्जरी किया फिर भी
New adjuvant HT plus chemo or ARTI. Over to the chairpersons for the next session. Dr. Anand.
అంతా అక్కడ అపోజిట్.
Good morning, everyone.
Okay.
Many thanks to the organizing committee for giving us this opportunity. We'll be speaking on neoadjuvant therapy for high-risk localized prostate cancer. That's before radical prostatectomy or radiotherapy. And Dr. Harshit from Max Vaishali would speak about hormone therapy, and after him, I will take on the androgen receptor signaling inhibitors, that's abiraterone, enzalutamide, and other drugs, and neoadjuvant chemotherapy in prostate cancer. So I would request Dr. Harshit to start off, and then I'll come in.
I respect chairpersons and the audience. Very good morning to all of you. It's an honor and pleasure to give the first talk for this session to the house full. So I